So we are live.
Okay. Good evening, everyone. I feel immense pleasure to welcome you all in this webinar and update of CRVO. At the outset, I like to welcome our dynamic president, Dr. Pranav Shah, secretary who is yet to join, but I welcome here only Dr. Vibhuti, and the most enthusiastic and vibrant chairman scientific committee, Dr. Satyajit, and all the officials who supported us to bringing out this webinar of academic research committee. This webinar is decorated by the presence of national speakers and the surgeon par excellence of all over from the India, Dr. Pritam Sir from Mumbai, Dr. Vivek Dave from Hyderabad, and Dr. Neeraj Sanduja from Delhi. I welcome you all, sir, and we are eager to hear from you. I welcome young PGs from the DMCH, Dr. Arvind, Dr. Harish, and Dr. Shivali, who is going to present here. I welcome all the chairmen and panelists of the session. Lastly, I welcome Dr. Ashif and Dr. Shivani, very keen ophthalmologist, as a moderator of this session. I convey my sincere thanks to Dr. Alka Jha ma'am, head of the department of DMCH, for allowing their DMCH faculty and PG to hold this webinar. And a special thanks to Dr. Satyajit, who worked very hard and supported me in bringing out this meeting. Thanks to you all. Now I request Dr. Pranav sir to say a few words of encouragement for the young generations.
Good evening, everybody. This is going to be a repeat. On behalf of Bihar Ophthalmic Society, I extend a warm welcome on this 12th February cold evening to Dr. Vivek Dave from Hyderabad, Dr. Pritam Samanta from Mumbai, Dr. Neeraj Sanduja from Delhi, our own speakers, moderators, chairpersons, panelists, and the audience. And congratulate our office bearers, especially the Secretary, Chairman Scientific Committee, Chairman ARC, Dr. Nagendra Prasad, for coming up with a meaningful webinar designed for the postgraduates and the young and the experienced ophthalmologists as well. Let's enjoy this evening with a comprehensive deliberation on such a common monster, CRVO, and try to find out a solution as to fix it to the earliest. I'd also like to take this opportunity to congratulate our colleagues on behalf of Bihar Ophthalmic Society for achieving incredible heights beyond ophthalmology. Dr. Sunil Singh for becoming the Vice President of IMA Bihar, Dr. Vibhuti Prasanna Sinha for taking up the post of Deputy Director IGMS Patna, Dr. Ashok Verma becoming the Honorary Secretary of IMA Bihar, Dr. Uma Shankar Singh becoming Principal of Bhagalpur Medical College, known as Jawaharlal Nehru Medical College, and Dr. B.S. Jha, who last year became the Medical Superintendent of SKMCH. These are the people who have set examples to find a place for themselves beyond ophthalmology, and it's really incredible. This webinar series by the ARC is primarily aimed to encourage the postgraduates and the ophthalmologists of the state. And I again like to thank Dr. Nagendra Prasad for having taken the initiative, and I would like to see that it is continued further in future also. So over to you, Dr. Nagendra, with these few words.
Thank you, sir, for your word of encouragement. And now I request Dr. Vibhuti Prasanna Sinha, who is the secretary of the Bihar Ophthalmological Society, and he is having a new address also, the Deputy Director Administration of the IGMS. Congratulations, Dr. Vibhuti, for being getting such an honorable post in your institute. Please say a few words for our webinar.
So thank you, Dr. Nagendra Prasad, sir. Being a guru of mine, it's always a proud privilege to work under you, with you. First time I'm seeing also the Chairman Scientific Committee working in tandem with ARC, and this program is going to percolate and showcase the complete picture. So I think Dr. Pranav Ranjan sir have already said everything. Welcome to the web speakers from across India. and our speakers also, they are going to do justice to the topic, and everyone is going to learn something new from tonight deliberations. Thank you once again. Thank you very much, sir.
Thank you, Dr. Vibhuti. I welcome Dr. Subhas Prasad. Dr. Pooja is here. Dr. Amit is here, and Vivek is here. So you are all welcome in this evening. Also, there is Siddharth is here. Now I request our moderator of the first session, Dr. Asif Sanawaz, to hand over to proceed for the further meeting.
Thank you, sir. I am thankful to Chairman ARC, boss Dr. Nagendra Prasad, sir, for giving me the responsibility of moderator in this session. First of all, I would like to invite chairpersons, Dr. Pranav Ranjan sir, President boss, Dr. K.S. Gupta sir, Vice President boss. K.S. Gupta sir has joined, or
he will be joining later.
Oh, Dr. Subhas Prasad sir, and Dr. Vishal Kishore. Dr. Vishal. Now I invite panelists of this session, Dr. Deepak Agarwal, Dr. Vivek, Dr. Abhishek Anand, and Dr. Divya Pandey. Now I request Dr. Satyajit Sinha sir, Chairman Scientific Committee boss, to introduce our guest speaker, Dr. Vivek Dave, and invite for him for presentation. Dr. Satyajit Sinha sir.
Thank you, Dr. Asif. I'd like to thank Dr. Nagendra Prasad sir for giving me this opportunity. It's an absolute honor and pleasure to be introducing Dr. Vivek Dave, who is a senior vitreoretinal consultant at LV Prasad Eye Institute, Hyderabad. He has had numerous publications and presentations in international journals and international conferences. He absolutely needs no introduction, because this program is especially for postgraduates, it's very important that they know all the important ophthalmologists who are doing yeoman work around the country. And Vivek Dave is, Dr. Vivek Dave is one of them. And it's an absolute honor and pleasure to welcome Dr. Vivek Dave. He will be talking today on endophthalmitis and mascarades, basic of medical and surgical approach. This will be his keynote address for today evening. Dr. Vivek Dave, please.
Thank you, Dr. Satyajit Sinha, sir. Thank you for that kind introduction. I will now shift to my presentation. Though this is a topic not in sync with the rest of the theme, but I hope there are certain points in this that the audience can take back and then apply in their practice, especially those who would go ahead and be doing their retina fellowships and pursuing a retina career. So I'll just share my screen now. Right. I hope my screen is visible, Dr. Sinha.
Yes, it is.
Yes, it is visible.
All right. So my topic for the evening is titled as endophthalmitis, the common presentations, the slightly uncommon ones, and mascarades, those that may in the first view seem to be endophthalmitis, but actually turn out to be something else. By definition, we know that endophthalmitis is inflammation of the internal layers of the eye with exudation in the vitreous cavity. So these are various photographs which show how typically endophthalmitis would look in our practice. There are different types that we know of with respect to classification. One could classify it as acute or chronic based on the time frame of presentation, and also based on etiology, you could put it down as a bacterial, fungal, and based on the mode of entry of the organism, it could be exogenous or endogenous. In this talk, we will touch upon post-cataract surgery endophthalmitis, and I will also touch a bit upon endogenous and post-trauma endoff to basically put across into perspective the various surgical and medical approaches that we have that change from presentation to presentation. Acute post-cataract endophthalmitis, something that worries us most commonly in our practice, is defined as something that occurs within the first 6 weeks of cataract surgery. Now, how do you suspect? You suspect it when post-surgery you see any unusual inflammation, any increasing pain, or decreasing vision. So once we operate, we would expect the patient to slowly gain vision. At the same time, all these symptoms would go down. So if you have a curve which is opposite, that is where you suspect. Now look at my first sentence. I've put it down as any unusual inflammation post-surgery. So what do we make of this word unusual? Now, all of us as cataract surgeons have been operating day in, day out, and we all know our clinical surgeon factor. We are aware of a surgeon factor for IOL calculation, but you can also put down something as a clinical surgeon factor, where I know if I operate X type of a case, I am likely to get Y amount of inflammation. Now, this is something that we intuitively have an idea as we keep on operating and keep on gaining experience. So anytime in the post-operative period, you see something which is deviant from what you would have expected in that given case, it should be a red flag, and you should observe that case closely for a diagnosis of possible endophthalmitis. How do we suspect? Well, the first 2 weeks are very crucial. If you do sort of a meta-analysis of the maximum number of post-cataract surgery endophthalmitis papers that are available in literature, and look at the time frames at presentation, you will see that over 80% have presented in the first 2 weeks. So that makes the first 2 weeks post-operative very crucial, where any sort of patient symptomatology should be given a year. You should try to hear that out and see whether anything that he or she is saying is indicative of a possible infection. The two gold standard or the biggest studies in relation to endophthalmitis, the endophthalmitis vitrectomy study and the European Society of Cataract and Refractive Surgeons, the ESCRS study, have put down a few signs and symptoms. And if you look at this table, you will see that blurred vision, presence of hyperemia, and most importantly, hypopyon and media haze. So if these things sort of come in the post-operative period, it should again raise a red flag as to whether you are dealing with endophthalmitis. When we look at management principles, you can divide it as into diagnosis, antibiotic and steroid therapy in association with the surgical interventions of vitrectomy and biopsy. Now, diagnosis as far as endophthalmitis is concerned is a clinical diagnosis. If you see a constellation of signs and symptoms that we just discussed, along with media haze, if you're not able to see the posterior segment, then you will be doing a B scan and you will be looking at echoes on the B scan. So if you have these constellation of signs and symptoms, you put it down as clinical endophthalmitis, and then you take the patient up into the OR for, on the minimum side, a biopsy. That means taking a sample with a vitreous cutter, and on the extended side, a vitrectomy, where you would clear out the vitreous cavity of all the infected vitreous. One should not aspirate. Now, aspiration is something that I personally used to do a lot, because that is what I was exposed to during my residency. But it is in my fellowship that I realized it is better to use a cutter and take a sample rather than aspirating from the vitreous cavity. The issues would be that the vitreous cavity may have very thick exudates. Hence, you may get a dry aspirate, not get any sample whatsoever. And secondly, aspiration, as we would understand, would cause a pull on the entire vitreous body, and you may cause peripheral retinal breaks. So something which may be an endophthalmitis that can respond well, you may have inadvertently complicated by creating a retinal break and causing a retinal detachment. So do not aspirate. If you want to take a sample, always take a small biopsy from the vitreous cavity. The general philosophy of any infection in any closed space, if you look at it surgically, would mean that an abscess cavity needs to be cleared. Hence, in today's time, and even if you look at recent upcoming literature, as far as visualization instrumentation and skill allow you, one should do a vitrectomy and not restrict yourself to a biopsy alone. A biopsy alone, in my understanding, I would suggest for those cases which are on the fence, that means just suspicious. In general, the eye looks fine. You have nice 6669 vision, possibly a trace hypopyon, and you have some doubt that this patient may have an endophthalmitis. In that situation, one may take an AC tap with a vitreous biopsy, or the extreme opposite, where the infection is so bad that the cornea has gone downhill either due to a keratitis or due to extreme corneal edema, and you're not able to see anything. Hence, you would take a biopsy alone. In my practice now, because I do a lot of endoscopic procedures, even a hazy cornea would not be sort of a roadblock to a vitrectomy, and I would go ahead and do a vitrectomy wherever possible. Let us come to a few surgical demonstrations. So this is a patient of endophthalmitis where the SICS tunnel had opened up, and you see that there is an infection. Now through the side port, putting in a cutter, I am taking a small vitreous sample. After having taken the sample, another important thing is that the anterior chamber would often have an inflammatory membrane. So I'm going in with a 26 gauge needle and sort of teasing the membrane of the iris. And once I get a plane along using a Sinskey hook or a visco cannula, one can actually dislodge the entire membrane, enlarge the MVR entry a bit, and then tease out along with a Sims forceps, tease out the entire anterior chamber membrane and directly plate it into a chocolate or a blood agar. This way, that's a good salvage of the sample which you can directly plate for microbiology. So this tunnel, in this case, I am suturing up because it had necrotic edges and there was a gape. Now, this is how the vitreous cavity should ideally be dealt with. Good visualization, clear off as far as possible. I'm a big believer of inducing a posterior vitreous detachment that ensures that the posterior hyaloid is free of the retina, and that allows you to come back to the mid vitreous cavity and clear off all the exudates comfortably. So here you see that we have been able to expose out the retina. You see a few hemorrhages on the posterior pole, but largely the retina is attached. And once everything is done, you can inject your empiric antibiotics. Empiric antibiotics, as of right now, the gold standard is still vancomycin plus ceftazidime. Some practices do prefer imipenem as the gram-negative coverage, and a lot of practices also prefer a combination of piperacillin, meropenem. But again, as far as standard literature is concerned, and if you look at the overall susceptibility, ceftazidime still seems to be doing the job in most practices. Once we have taken the sample, another or the secondary role that comes in is of the microbiology lab. If you have an in-house lab, then all of this can be immediately expedited, or the sample could be sent to the collaborating laboratory in the city. They usually would do a Grams, Giemsa, and calculfluor white staining for the smears. If one sees organisms, then obviously there is an infection. But even if you do not see organisms, if you look at the micro reports carefully, they would also report what are the types of inflammatory cells that were seen. So you may see a report which says no organisms, 10 to 15 polymorphs per high power field, or no organisms, polymorphs plenty per high power field. So whenever you have such a microbiologic report, it is an indirect evidence that there is intense inflammation that has been incited in the vitreous cavity. And though the smear could not pick up the organism, this becomes an indirect evidence that there is likely to be infection. So this is from a published study in 1996 in the journal Retina by Dr. Savitri Sharma et al. Other than the smears, the sample is also to be taken for culture in agar plates and liquid media. And if there is adequate sample that has been taken and you have availability of the technology, additionally PCR for eubacterial or fungal DNA differentiation can also be sent for. If you look at general management guidelines, like we said, vitreous sample needs to be collected at the first intervention. Empiric antibiotics would include currently vancomycin and ceftazidime to give a good all-round coverage. Immediate smear examination, if you have an in-house lab, is very ideal. You can actually wait on table, just like general surgery or oculoplasty would wait for a frozen section for margin clearance. You could wait on table for the microbiologist to tell you whether they see anything on smear. If fungal filaments are noted, then intravitreal voriconazole or amphotericin B can be injected right there and then on table. So what do we do for prevention? Now, as far as prevention is concerned, we know that in general, in most practices, the endophthalmitis rates nowadays are very low. But still, even if one endophthalmitis occurs, it becomes a very important event. Going by the AIOS guideline, one should try to see that one does not take up a patient for surgery if the sugars are more than 200 mg%. Now, this is a working guideline. You do not really have very hard evidence as to what the blood sugar level should be. But because this is something that is propagated at the national level, all of us are in good stead if we follow this as a common guideline. One should check regurgitation over the lacrimal sac area before posting the patient for surgery. In case you find that it is positive, the cataract surgery should be postponed and should only be taken up after a DCR is done. Suppose you have something which is like an emergency cataract surgery, say for example, phacomorphic glaucoma. In that situation, a short procedure like a DCT can be done and a cataract surgery can be done immediately after that. One should not syringe the lacrimal passages just before surgery, because in case there are any organisms there, they would come out into the cul-de-sac and increase the risk of infection. Rest of the things in terms of appropriate sterile OR clothing, noting batch numbers of all consumables entering the eye, and a low threshold to suture the wound in case there is any doubt of leakiness, also are good ophthalmic practices to prevent endophthalmitis. Very important, though it would be once in a blue moon event. In case it happens, one will have to fall back and see what all things were used and what all went around in the perioperative period. Hence, documentation of pre, intra, and post-operative findings is paramount. The only known standard guideline for medical prevention of endophthalmitis per se is cleaning the skin and periorbita of the eye that needs to be operated by povidone iodine 5% for about 3 minutes, and also instilling the same in the conjunctival sac for a minute. Once we apply povidone around the periorbital area, it is important to wait, give it a waiting period and let it dry and not really wipe it off. So that is one standard guideline which is sort of followed all over the world. So in case after all this we do get an end off, it is important to examine the patient in situations where a retina colleague is available. Prompt retina referral and management is advocated. There should be a clear dialogue with the patient and the relatives where we can clearly explain that the condition is still treatable and that patient cooperation and possible referral to a second specialist may be required. Do not hold the patient close to you constantly for a long follow-up. It is always open and transparent to have a second opinion or a peer review, ideally to a higher center. If this is done, it not only diffuses out the tension, it also puts across a message to the patient that you are on his or her side, are not leaving him or her in the lurch, and are supporting to see what can be done best in the situation. And as we said, we should culture all solutions that were used and fall back upon documentation to see what all went into the eye, and does any of those solution, does it grow any organism which can give us a lead as to what the endophthalmitis was due to. Now let us come to a little unusual situations. We talked of a classical end-off, clear cornea, relatively easy to operate. Now what if the cornea is hazy? Now herein I'll bring in the element of a post-trauma endophthalmitis. So jagged wound, well repaired, and now you see here I'm trying to clear off the inflammatory membrane from the anterior chamber. But moment I put the conventional biome, I struggle to see anything inside at all. So that is where endoscopy becomes a very good tool. Herein I am entering endoscopically, and if you see there is a huge difference. All the exudates inside are clearly visible. They are amenable to good PVD induction and clearance under very good visualization. This allows us something which we would not be able to do through that hazy cornea, that is really go and clear the vitreous cavity pretty deep, right close to the retina. And as you would see at the end point, once the vitreous cavity is cleared, we are actually able to reach the retina, assess the health, and get some sort of an idea about the prognosis of the eye. Now, what if there is a localized deep retinal lesion? The first video where we saw the vitreous biopsy being taken, that is the conventional vitreous biopsy, which is taken from the anterior vitreous. Now, if you have a situation like what is shown in this case, where the focus of infection is very deep close to the retina, in these situations, if you take a conventional biopsy right from the anterior vitreous, you may not get much. At the same time, if you do vitrectomy to reach right behind, you may dilute the vitreous. So what you do here is, instead of infusion, you connect air. Hence, the air maintains the tonicity of the eyeball, wherein you are able to go close deep to the retina. And once you are there, you are able to pick up sample from deep retina and from over the infected lesion. Once that thing is done, one can again induce a careful posterior vitreous detachment. We can see a nice wise ring coming up that will ensure that the posterior hyaloid gets separated and the entire vitreous infected with the organisms and the exudates is amenable to good clearance with the vitreous cutter. Now, one unusual thing, again, we shift gears back to cataract surgery. Now, this was a patient who had cataract surgery done about 6 months ago, was diagnosed to be having a posterior capsular opacity and was advised YAG cap. Just on the day when the patient came for YAG cap, his eye was red and the patient was sent back in view of possible conjunctivitis. Now, what was happening is this redness kept on coming on and off, on and off, on and off. So herein, if you see this patient carefully, you see that it is not really your typical posterior capsular opacity. Instead, what you see are small flocculent white sort of lesions which are there in the peripheral capsule of the eye. So this is something which should indicate that this is a possible infection, a low-grade infection, which is causing the eye to be continuously get inflamed. So this patient underwent vitreous biopsy, pars plana vitrectomy, intravitreal antibiotics, did settle down for a while, but again flared up, and hence an IOL explantation was planned. The original vitreous biopsy did not grow anything, but when the IOL was explanted, there was growth from the capsular bag. This growth was of yeast, and the Vitek machine, which actually gives us an identification, identified it as a cousin of Candida, which is Staphylococcus cephali. Finally, the eye settled down fine, and with time underwent a scleral fixated IOL. So what this case tells us is, in case you see repeated inflammation, and in those situations, you see a lot of granulomatous scapies. I could not demonstrate it on the slit lamp photograph here, but if you see a lot of granulomatous scapies come up post-cataract surgery in an eye which doesn't seem to be settling down well, it is very important to look at the peripheral areas of the IOL, and you may see white matter stuck there along the IOL, which could indicate a low-grade or a chronic endophthalmitis. TAS is something which we are all aware of: limbus to limbus corneal edema, early onset, high IOP, no vitritis, and dramatic improvement on steroids. Often it is a therapeutic diagnosis rather than anything else. There is a whole list of things that could lead to TAS, and basically it falls back upon how you are cleaning and maintaining your instruments. So to prevent TAS, it is important that the entire surgical team is absolutely aware of all instruments and how to handle them. There is regular sensitization of all staff with respect to instrument handling and sterilization. You use disposables as far as possible. Clean all your instruments with oil-free compressed air. And as mentioned in one of the previous slides, document diligently about all sterilization protocols that you have followed. Mainstay is prevention. In case you get a TAS, again, you need to go back, medically manage as per the slide that I just showed, and epidemiologically investigate things backwards to try and see where the original source of inflammation in your OR lied. We finally come down to two additional masquerades that can present in endophthalmitis. Now, this is an eye day one post-cataract surgery. So you see a small hypopyon. Moment you see a hypopyon, yes, you are thinking on the lines of endophthalmitis. But one thing I would want to draw your attention to is look at the color of the hypopyon and the fibrin in the pupillary plane. It is white. It is not clearly looking, off-white or yellow. So this, when it looks white, this is an indication that this could be a possible inflammation. This patient undergoes a B scan. The B scan comes out to be normal. So you see an anterior chamber which is this inflamed, but B scan looks normal. The membrane is whitish in color. The lids do not show edema. The patient does not have significant pain. So all of this points towards a possible inflammation. What this patient would require is intense steroids. Still, there is a possibility or outside chance that this may be infected. So what is usually advised is these patients should be either admitted or be at close follow-up so that they can come back to you at 12-hourly intervals. You put these patients off antibiotics, put them on cycloplegics and steroids, and see how the inflammation goes down. Now, this is the eye 24 hours later. You can see the anterior chamber from what it was before has started showing consolidation of the membrane. The membrane has started becoming more and more prominent and it's constricting. And another 3 days down the line, you see that the membrane has well constricted. And about a week and a half down the line, the entire area is clear and you only see a small sort of a muck left on the capsule. So this is an overt inflammation. In literature, it is also called as non-infectious endophthalmitis. This is one paper from JCRS which explains or in detail gives the explanation of how these cases present vis-a-vis a proper or a full-blown infectious entity. Now let us come to this last couple of slides. Very sort of typical presentation, but something that you would see once in a while. This patient was referred to me from Maharashtra as a case of delayed onset, late clinically fungal endophthalmitis is what the referring doctor had told me. Now, cataract surgery was done 8 to 10 years ago. Now, we all know delayed onset endophthalmitis does occur months down the line, sometimes years down the line. But the first red flag to the diagnosis is 8 to 10 years ago. So that's a real long amount of time for an endophthalmitis to occur. So this is the whiteness that the patient noticed in the last few weeks, apparently. And there was mild discomfort in vision. And this vision loss was fluctuating. So the patient said that the vision would change as per his position. If he would lie down, the vision would come down. If he would sit up after some time, the vision would become relatively okay. The anterior chamber was quiet. And what the patient had, according to the referral letter, was a possible hypopyon in the capsular bag. B scan was normal. Fundus on examination was completely normal. Now look at what this thing actually turns out. So I do an anterior segment OCT. What do I see? I see the iris, I see the IOL, and I see all this whitish material which had now got spread out throughout from limbus to limbus because the patient was lying down. Also observe how there is no space between the IOL and the iris. So what basically had happened over the years is a zipper closure occurred between the IOL and the iris. There may have been some amount of lens matter or some amount of epithelial cells in the capsule, which over a period of time proliferated and aggregated in the capsule. So this is a condition known as the capsular distension syndrome. So it rarely occurs after cataract surgery. Decrease in visual acuity is due to a refractive shift because the IOL is actually pushed ahead or pushed behind from its actual location, and also because of turbidity of fluid in the capsule. So no infection here. All you require is a simple ND yak cap. That is what was done. And this is the patient half an hour after ND yak cap. So this is what he was at presentation. And this is immediately after yak capsulotomy. You can see the capsule behind, which has opened up because of the laser. And you see all the material that was there before has completely dispersed out. So once in a while, certain things can present as if they are a hypopyon or a possible endophthalmitis, but it is important to evaluate the entire history and each and every piece of the clinical evaluation to come down to the correct diagnosis. So in conclusion, facing endophthalmitis is inevitable. All of us are going to face it someday or the other. What can help us if we remember that we need to have a good documentation, we need to be able to differentiate it from certain other common differential diagnosis. have a good dialogue with the patient with respect to what he or she is having, a definitive sampling and a definitive vitreous clearance, direct microscopy, culture and PCR as per available facilities, and a diligent follow-up. So if we do all this, we at least from our end would be doing the best for the patient. Of course, what visual acuity would be salvaged is something which is not under our direct control. So thank you very much for your kind attention. And in case there are questions, I can quickly take a couple of them. Thank you.
Thank you, Dr. Vivek. Thank you for that amazing presentation. It almost felt like a postgraduate. I could write the whole long question answer with this presentation. And I was just remembering one patient 25 years back who I just saw the capsule. She said my vision had decreased and I just went ahead and did a Riag capsulotomy. And don't ask me the sequel, what happened after that about the long story of P. acne. So it's very important to recognize things. Indeed, a wonderful presentation. Thank you so much for your time and presentation. Thank you so much. Over to Dr. Asif, please, for the conducting further.
Thank you, sir.
Just one question, Dr. Vivek.
Yes, sir.
How do you rate the draping of the eyelid? Because one of our study I have gone through that, it shows that the rather finding the organism from the culture from the conjunctival sacs, we do get culture positive from the eyelashes and all. So the draping of the eyelid is how much stress upon nowadays.
Yeah, I think draping of the eyelid is extremely important for the reason that once we put the speculum and any stretch or pressure on the speculum, if one observes closely, there can be expression of meibomian secretions from the meibomian glands. So I think putting a drape very carefully, and in case the eyelashes are exposed, rather than cutting the eyelashes and proceeding with the surgery, I think we are in a better stead if we just stop, remove the drape and drape sort of all over again. One can also take sort of a second layer of protection by using specula which have the flanges which sort of cover the eyelid. So an additional protection in addition to the drapes. But I think that's a very important point that you have raised. Eyelids should be very clearly put away from the entire operating field.
Thanks for that.
I would like to ask just a few quick questions.
Yes, sir.
How do you rate the intracameral moxifloxacin after during surgery?
Yeah, extremely important question. We actually have looked a lot into our data, which has got published recently. So if I can quickly summarize, intracameral moxifloxacin, if you use during cataract surgery, what we have found in our well-documented internal data is we did not find a drop in the endophthalmitis rate by using intracameral moxifloxacin. Now, this is different from the statistic world over, where the clear message is if you use intracameral moxi, your end-off rates would come down. For us at LVPI, the end-off rates are same, but if you get an end-off following intracameral moxifloxacin, the overall clinical course is milder. They tend to require lesser repeat interventions, and the final visual acuity achieved is significantly better than what we had when moxi was not used. So I may still get an end-off, but I will possibly come out of it better if I use moxi, is what our in-house data suggested. This has, I think, come in 2-3 months ago in IGO.
Okay, very nice.
Okay,
I could. Yes, Dr. Panaranjan, sir.
Yeah, then I go ahead because there are a lot of questions. Otherwise, we'll get delayed.
Okay, I just sorry for the interruption. I could see here Dr. Alka Jha ma'am, as head of the department of DMCH, Ophthalmology department. Could you speak a few words about this webinar, madam? Because it is your PG who are going to present, and Asif is here moderating the session. Just a little.
Welcome, Dr. Alka Jha ma'am. Can you unmute yourself, madam?
Unmute, madam. अनम्यूट करना होगा मैडम आपको.
Madam.
Yes.
Yeah.
Yes, it's a good presentation going on, and my PGs are joining soon, very soon. So it will be nice to hear from them. So it's
Thank you, madam.
good
Dr.
to see you
Asif.
all of you are joining here. So
Thank you, madam. Dr. Asif, please carry on.
Thank you, madam, for supporting us.
Thank you, sir. Now, I would like to call upon Dr. Arvind Kumar for his presentation on applied anatomy and pathogenesis of CRVO. Dr. Arvind Kumar is final year postgraduate student at DMCH. He has done his graduation from ADMCH, Gaya. Dr. Arvind.
Share your screen, Dr. Arvind.
Yes, sir. Good evening to all. I am very thankful to boss officials and chairperson ARC, Dr. Nagendra Prasad sir, for giving me opportunity to present my topic in this forum. Today, my topic is applied anatomy and pathogenesis of CRVO. Good evening, respected chairpersons, panelists, and learned audience. Today, I'm going to present blood supply of the retina. Internal carotid artery give a branch to the eye known as ophthalmic artery. It further branches as a ciliary artery and central retinal artery. Central retinal artery supply the inner 2/3 of retina from internal limiting membrane to outer plexiform layer. Another ciliary artery give a branch known as choriocapillary artery, which supply the outer 1/3 of retina from outer nuclear layer to retinal pigment epithelium. Venous drainage of the retina generally follow the arterial supply. Central retinal artery or end artery enter the optic nerve approximately 1 centimeter behind the groove. There are 3 anatomical layers: intima, media, adventitia. Central retinal vein mainly contain a smooth muscle, elastic tissue, and are relatively distensible. As retinal vein move periphery from disc, lumen size decrease from 150 micron to less than 20 micron. In addition, 3 or 4 layers of a smooth muscle cell along wall are replaced by pericytes. These layers of pericyte lack the contractile and structural strength, so luminal size and vein are flexible. This picture shows the arrangement of central retinal artery and central retinal vein at the level of the disc. Capillaries throughout the retina, the capillary are spread like a vast cobweb. Only 3 areas devoid of the capillaries: foveal or vascular zone, retinal adjacent to major artery and vein, far periphery retina. Capillary wall mainly contain endothelial cell, intramural pericyte, basement membrane. Disease involving the endothelial cell disrupt this normal physiological barrier and result in exudation of protein and lipids. Pericyte provide the vascular stability and as something is missing. Pericyte provide the vascular stability and control the endothelial proliferation. As we know, new vessels lack pericyte. There is a loss of vascular stability and are prone for rupture and hemorrhage. Pericyte contain contractile protein and may function like a smooth muscle in controlling flow through capillaries. Loss of pericyte result in formation of the microaneurysm. Central retinal vein and artery share a common adventitial sheath at arteriovenous crossing posterior to the lamina cribrosa. This picture shows the central retinal vein compression and turbulence blood flow, allowing for the thrombus buildup. Pathogenesis: the disease involving the retinal vasculature can be divided into following categories: vascular occlusive disease, inflammatory vascular disease, vascular tumor of the retina, other vascular abnormalities, vasculopathies associated with systemic disease like hypertensive retinopathy, diabetic retinopathy. Vascular occlusive disease divided into following categories: retinal arterial occlusion, retinal vein occlusion, ocular ischemic syndrome. Since common adventitia shared by artery and vein, if any pathology causes thickening of the arterial wall, can compress the retinal vein. If there is compression, it can causes increased turbulence flow in the vein and narrow venous lumen. Also, systemic factor, inflammatory factor, arterial crossing compression, neurovascular compression can responsible for narrowed venous lumen and increased turbulence, which lead to the venous thrombosis and finally resulting in the vein occlusion. If vein occlusion is there, can causes the neovascularization, edema, and hemorrhage. This is a video beautifully present the pathogenesis of CRVO.
यहाँ से नहीं प्ले होगा, उसको वहां से प्ले करो अगर कहीं रखे होगे।
हाँ सर, एक सेकंड सर।
उसमें लैपटॉप में होगा कहीं से, तो वहां से play।
एक सेकंड सर।
लैपटॉप में कहीं होगा तो वहां से ओपन कर लो उसको, इसको क्लोज।
जी सर। Sorry, sir. I am sharing a new screen.
No.
If it's not working, maybe we can move to the next speaker.
Yeah.
Sir, bus.
You can probably log in and try again.
In the meantime, I update the latest news that instead of Dr. Rajesh Agarwal, Dr. Gautam is going to present his topic here at the end of this session. Welcome, Dr. Gautam. I think
Dr. Arvind, कोई दिक्कत नहीं है, घबराने का जरूरत नहीं है. We are right here. You can take your time to log in again.
Yeah.
Okay, sir. Thank you, sir.
Don't panic.
Okay.
Good, good.
Just a minute. Now we can play.
Sorry for interruption, sir. This is the video.
अगर ये स्लाइड नहीं चल रहा है तो उसको स्किप करके नेक्स्ट स्लाइड में चले जाइए.
Sir, can you see?
Yeah, we can see.
Dr. Arvind, you can stop your camera.
Yeah.
Yeah.
Dr. Arvind, you can stop your camera just for the consumption of less consumption. Better. I think you can now proceed.
No, okay. Let's play. Can we move to the next topic? By the time he ready his presentation, we Unmute, Asif.
Now, I would like to call Dr. Shivali Raj. Say, Dr. Arvind, the video after this, Dr. Shivali's presentation, we will. Now, I would like to call Dr. Shivali Raj for her presentation on clinical features of CRVO. Dr. Shivali is third-year postgraduate student at DMCH. She has done her MBBS from NMCH Patna. Dr. Shivali, please share your screen.
Yes, sir. Very good afternoon, good evening, and I would like to thank BOSS officials and Chairman Scientific Committee, Dr. Nagendra Prasad sir, to speak in this forum. Today, I will be speaking on the signs, symptom, and clinical features of central retinal vein occlusion. Also, I would like to say good evening to all the respected judges, panelists, and the learned audience. Now the topic is signs, symptom, and clinical features of retinal vein occlusion.
Doctor, sorry to interrupt. We are not able to see your slide as of now. Can you just stop share and then reshare?
Yes, sir. Yes. Sir, is it okay now, sir?
No, it is not.
Can you just stop share? Can you just stop screen share and then reshare?
Okay, sir. Okay.
Can you reshare now, please?
Okay, sir. Should I start, sir?
Please share screen, Doctor.
Share your screen.
First, open your presentation and then do the screen share.
Okay, sir. Okay. Is it okay, sir?
No, it is not.
No.
First, you just stop screen sharing and open your presentation, then share the screen. Then
okay,
it will
sir,
come.
Okay.
Open your presentation. Now stop screen sharing.
Dr. Shivali, can I guide? Can I help you, Dr. Shivali?
Yes, sir. Yes, sir. Hi, yes, sir, please, sir.
I am stopping it. Just a second.
Okay, sir. Okay.
On the Zoom window, can you do it, Dr. Shivali, yourself for a minute?
Okay, sir.
On the green on the Zoom window, there is a green button. Just click on it once.
Yes, sir.
And the pop-up will come. There will be a blue button on the right-hand side. Just click it. The share which says share. Just click again. Green button and then blue button. First, do the screen share on the Zoom window, and a pop-up will happen, and then the green button. Yeah, perfect.
Yeah.
So, is it okay, sir?
Yeah.
Slides.
Okay.
Slideshow. Go to slides.
Slideshow में चले जाओ.
Okay.
Now,
should I start, sir?
Yeah.
Sure.
Okay. Sorry for interruption, and very good evening. And I would like to thank the sir, Dr. Nagendra Prasad sir, Chairman ARC, for giving me this opportunity. Also, the respected chairpersons, learned audience, and all panelists. Topic of my talk today is symptoms, sign, and clinical features of central retinal vein occlusion. First, the venous occlusion classification of venous occlusion based on the site and size of the veins can be central retinal vein occlusion and hemiretinal vein occlusion, and both present as ischemic and non-ischemic. Branch retinal vein occlusion may present as major macular and the peripheral one. The occlusion site is at the lamina cribsa, and CRVO is usually unilateral disease. However, 7% risk of developing CRVO in fellow eye by 5 years. Rarely, cilioretinal artery occlusion may occur in association with CRVO. Classically, the patient presents with the sudden painless monoocular loss of vision, but it may also present with the history of gradual visual decline if there is subclinical previous episodes, dilated tortuous retinal venous system, interretinal hemorrhages, both superficial and deep, involving all the four quadrants, hemorrhages radiating from the optic nerve and optic disc edema and cortical spots. Types of CRVO is ischemic CRVO and non-ischemic one. The ischemic is basically the hemorrhagic CRVO, and the non-ischemic is venous stasis retinopathy. So why to differentiate and how to differentiate? Since the visual outcome, prognosis, complication, and also the level of management are different in ischemic and non-ischemic CRVO. So essential to determine the type. We can differentiate the two entities based on the following signs: whether the presence of RAPD, visual fields by Goldman perimetry, ERG, fluorescein angiography, and the ophthalmoscopic features. Key features to differentiate is visual acuity greater than the 660 in the non-ischemic, and the ischemic varieties presents with the low visual acuity even at the presentation less than the 660. Visual field defects are though rare in non-ischemic, and profound visual field loss are there in the ischemic one. Very few cases of non-ischemic present with the RAPD. We can measure it by the neutral density filter. It may be a 0.3 log unit or less it can be. And in the ischemic variety, there is marked RAPD greater than 1.2 log unit. Hemorrhages in the non-ischemic are not so extensive, and in ischemic, extensive hemorrhages are present. We can measure the ischemic index based on the fluorescein angiography. Less than 50% of ischemic index is there that corresponds to the less than 10 days diopter of the area being involved. And in the ischemic variety, greater than 50% of the area is involved. ERG, the AB ratio is greater than 1 in the non-ischemic and less than 1. The amplitude of the B wave is reduced, and the neovascular complications of iris and neovascular glaucoma are rare in the non-ischemic one, and however very common in the ischemic varieties. The non-ischemic also called as the perfused CRVO, the venous stasis one, is more common than the ischemic. About 15% cases of non-ischemic CRVO in course of time, in 4 months, convert to the ischemic one, and about 30% in 3 years. So the patient of non-ischemic CRVO classically presents with a sudden painless and monoocular fall of vision. On examination, the initial visual acuity is better than 660. In few of the cases, RAPD is present, and in some may be absent. Dilated venous tortuosity and dilatation of all branches of central retinal vein is there in all. In all quadrants, we will find mild to moderate retinal hemorrhages involving the posterior pole and also the periphery. Mild to moderate disc edema is there. Cortical spots are variable, though few, and the visual prognosis is guarded depending upon what the area of macula it involves. And it may convert to the ischemic one. We can see the fluorescein angiographic picture of the perfused type of CRVO. There is early phase this is early phase angiogram. We can see the good capillary perfusion network in the parafoveal capillary network, and comparing it with the fundus photograph, where we can see the tortuous vein in all and also the hemorrhages in all the quadrants. The acute disease, though presents with the venous congestion, tortuosity, and hemorrhages, when we do the autofluorescence, very fall-like perivenular autofluorescence is there. In 6 to 12 months, the acute disease converts to the chronic one and presents with the venous seething, retinochoroidal collaterals around the disc, chronic macular edema, and observed retinal hemorrhage. We can see the fundus photograph of the early and late phases. In late phases, there is venous seething and hemorrhages are a bit absorbed. the optociliary stents or collateral vessels present in both the entity, more common in the ischemic one. And we can see the fundus photograph where the collaterals present at the inferior border of the disc, and these vessels actually are different from the new vascular vessels. They don't leak on the angiography. Main poor cause of the vision in the non-ischemic is presence of chronic macular edema and secondary atrophy, and 1/3 of the cases of the non-ischemic is going to convert in the ischemic one. We should always be alert and warn the patient if the vision deteriorates or any patient develops any pain or redness, since it may signify the development of a neovascular glaucoma, or also the development of significant ischemia may be there. So now the ischemic or non-perfused type of CRVO, patient is classically going to present with a sudden, severe and painless monoocular visual impairment. Occasionally pain, redness and photophobia, as we discussed, if the neovascular glaucoma is there. Also the prior reduction in the vision with the less severe preceding episodes, and patient presents with the visual acuity in the ischemic variety, very low visual acuity, finger count or even worse. Related RAPD is very much marked, and the fundus retina having the extensive hemorrhages, giving the tomato splash appearance and blood thunder appearance. And this edema is severe one. Cortical spots are variable and more than 6 to 10 even, more than the non-ischemic one. And macular ischemia is there, and the prognosis is poor. 50% cases have the rubiosis, iridis, and angle neovascularization. 9 to 12 months, where the acute signs tend to resolve and macula develop the pigmentary changes. Epiretinal membrane and the cystoid macular edema is the cause of poor visual outcome. Vitreous hemorrhage, breakthrough vitreous hemorrhages are also there in few of the cases due to the neovascularization, which that may be present at the disc or at the periphery. Fibrovascular proliferations from the neovascularization may result in the retinal detachment in few cases also. Here, the iris neovascularization, we can see they typically begin at the pupillary border and may tend to cross the iris surfaces. High risk of neovascular glaucoma, the 100 days glaucoma, elevated IOP, and peripheral anterior synaptic formation is the hallmark there. But in most of the cases, it is open angle, undilated gonioscopy is performed in every case, and we can see the fine branching vessels, the scleral spur, and more common in the ischemic one. Fluorescein angiography of the central retinal vein occlusion. We can see the greater than 10 disc area of non-perfusion, and also the arteriovenous transit time is low, delayed. And ERG is done where we are calculating, assessing the risk of neovascularization. And cystoid macular edema, we can do the OCT. In non-ischemic CRVO, 50% of the cases have the poor visual outcome at 660, but in the ischemic one, 90% of the patient. Macular edema and neovascularization and also the neovascular glaucoma are major cause of visual morbidity. Thank you. Yes, sir.
If you're there.
Excellent presentation, Dr. Shivali, and very well differentiated between the ischemic, non-ischemic, and the overview of the etiopathogenesis and clinical feature of the CRVO. Any question, please, you can ask. Dr. Subhash Prasad, anything you want to add?
She has done excellent presentation. Out of this, the clinical picture, what we see in the ischemic and non-ischemic, that is not very much informative many times. Sometimes even the non-ischemic may look like ischemic variety. So what is most important, or you say that most sensitive is the RAPD and this ERG, that is much more reliable, but obviously we cannot have all this facility, or we not have neutral density filter. In that case, many times we have to depend on the clinical picture. But what I follow that, if I see a lot of hemorrhages and large area of involvement with disc edema, then I generally label it at ischemic variety. So she has very well presented everything. But according to Swan Singh Here, the most important, or I think the sensitive parameter is the ERG and the RAPD actually.
Yes, very well documented. Also, the visual
Thank you.
acuity at the time of presentation gives
Visual
some
acuity is
input
also.
of whether, visual acuity gives whether the patient is ischemic
Less
or
than
not.
360 is very much indicative.
Thanks, Dr.
Thank you.
Shivali.
Can I make a comment here?
Yeah.
Yes, sir. Sure.
Most welcome.
I think it was a fantastic presentation. She covered all the aspects, the clinical aspects very well. And I was just about to say something, but Dr. Subhash said that is so the Sohan Singh Haire, Dr. Sohan Singh Haire, who I think is like a father of central retinal vein occlusion, because he has done some path-breaking work in this particular disease, medical retina disease. And one thing in the pathogenesis which and he's done path-breaking research, means he has sort of done the histopath on eyes, which develop CRVO, and actually found out where exactly the pathogen is, how what leads to a non-ischemic versus a ischemic CRVO. And one thing which in one of his monologues he writes is, it is the place where the actual thrombosis happens. The more proximal the thrombosis, the patient will develop a non-ischemic CRVO. And the more distal the thrombosis inside the central retinal vein, inside the optic nerve, then there is a higher chance of a ischemic CRVO. Hats off to Sohan Singh Haire, who came up with all these, gave us a better understanding of this disease. That's just what I wanted to comment. Thank you.
Thank you, sir. Thank you, sir. Thanks, Shivali, for your excellent presentation on clinical features of CRVO. Now, Arvind, are you ready with your video? Dr. Arvind?
If not ready, we can move on to Dr. Gautam.
Yeah.
Now I invite Dr. Gautam Kumar for his presentation on diagnosis and management of CRVO. Dr. Gautam has done his post-graduation from PMCH and done his long-term retina fellowship from Arvind Eye Hospital, Madurai, and presently working as a retina consultant at ASG Eye Hospital, Patna. Dr. Gautam.
Thank you so much, sir. I'll try to share my screen.
इधर नहीं आ रहा है.
Sir, just click on the green button on the Zoom window, which says share screen bottom.
Okay.
And pop-up will happen. Then on the right hand side, there's a blue button which says share. Usko click kar dijiye.
But it says open system preferences, security and privacy.
You are on Mac, then you will have to allow it on open system preferences, and then you have to allow it. It will just take 30 seconds. Just allow. Done, sir?
1 second. I'll have to quit and reopen, it says.
Yes, do that. Where is Dr. Arvind?
He's not responding. I've asked him to unmute.
Okay.
Actually,
Akbar, you have to tilt your phone. We are seeing you upside down.
Yes.
Perfect. Ab aa gaya. Go ahead, you can start.
Yes, sir. Yes, sir. Thank you so much, sir. Thank you for the invitation. I'll be talking on role of investigations in diagnosis and management of CRVO. So, as far as the etiological workup of a case of CRVO is concerned, in general, a systemic workup is not indicated in a person older than 60 years of age with known systemic risk factors for CRVO. If the patient is having a CRVO and he's 60 years or 70 years old and he's having known risk factors of diabetes and hypertension, we don't need to put him through a battery of investigations. We can just go on with the other investigations, further investigations. Now, workup is generally considered in younger individuals without common risk factors and in those with a prior occlusion in the fellow eye. For example, a patient who has had a CRVO in the other eye and now is presenting with CRVO in the second eye, or a bilateral simultaneous CRVO. As you can see in the picture above, this patient presented with a bilateral simultaneous CRVO and was later diagnosed to have multiple myeloma. And the picture below, this patient presented similarly with a bilateral CRVO and was later diagnosed with chronic myeloid leukemia. So in these cases, we need to investigate further. And we also need to investigate if the patient is presenting with a mixed type of vascular occlusion, if he has an arterial component, if the non-perfusion is severely worsening, if he has had a prior thrombotic disease, if he has got a family history of thrombosis, or other symptoms suggestive of a hematological or rheumatological condition. Now, what are the investigations that we advise for the patient? We can get a blood pressure, rule out hypertension, ESR, CRP to see his inflammatory state, complete blood count, of course, random blood glucose to see if he's a diabetic, a random total and HDL cholesterol, plasma protein electrophoresis because dysproteinemias will be there in multiple myeloma, urea electrolyte and creatinine will be done because the renal disease can lead to hypertension. Then thyroid function tests are a must because it is associated with dyslipidemia, which can further lead to a CRVO. Then we can also get a chest X-ray done, for example, to rule out sarcoidosis or tuberculosis, thrombophilia screen, including TT, PT, APTT, all those things, because they can lead to a hypercoagulable state and can lead to a development of CRVO. Then autoantibodies have to be done to rule out any those conditions, rheumatoid factor, anti-nuclear antibody, and anti-DNA antibody, serum angiotensin converting enzyme again to rule out sarcoidosis, fasting plasma homocysteine level, very important in a patient of CRVO, particularly if he is young, then triple-normal serology to rule out syphilis, carotid duplex imaging can be done to exclude ocular ischemic syndromes. Then after we have made the etiological, after we have done the etiological workup, we move on to OCT. The optical coherence tomography provides high resolution imaging of the macula and is extremely useful to detect the presence and extent of any associated macular edema, vitreoretinal interface changes, and subretinal fluid. Now, all the large clinical trials testing anti-VEGF treatment are based largely on using quantifiable OCT measurements rather than the more subjective stereoscopic photographs or clinical examination to evaluate and follow the macular edema. So OCT is a must. In clinical practice, of course, treatment decisions are commonly based on OCT measurements. For example, the decision to repeat anti-VEGF injections, change the injections, maybe to use steroids, initiate laser treatment, or even consider vitrectomy is triggeredly based on both visual acuity and OCT findings. So OCT is a must. Now, there are certain OCT biomarkers that have been described in relation to an RVO. For example, we can measure the central retinal thickness, the CRT, which is probably the most important biomarker in such a case. Then we can also see whether there is an intraretinal fluid, whether there are intraretinal cysts, IRC, subretinal fluid is there or not. Hyperreflective foci have also been described in relation to CRVO. Then drilled disorganization of retinal layers, and whether there is any VMA or VMT, that is vitreomacular adhesion or vitreomacular traction, is present or absent. But the most important among these is CRT. Now, there was a short study which was published in 2020. In this study, it was they published that the only SD-OCT feature associated with baseline vision was ELM disruption, and no other imaging biomarker was independently associated with visual gains after monthly ranibizumab injection. So, probably the most important biomarker in a case of CRVO is central retinal thickness and maybe ELM disruption or photoreceptor disruption. Now, coming to the next investigation, that is FFA. Now, fluorescein angiography is used to evaluate the extent of vascular occlusion, the degree of ischemia, and the extent of macular edema. Angiography can also identify macular capillary non-perfusion, that may explain the associated vision loss as well as the response to therapy. Now, useful technique, it is also a very useful technique to distinguish collateral vessels which do not leak fluorescein in later frames from retinal neovascularization that is associated with late leakage. So it can be used to distinguish collaterals from new vessels. It can also be used to identify regions of peripheral non-perfusion, helping to guide effective laser treatment or possibly detecting areas of untreated CNP areas that may explain persistent retinal or disc neovascularization that remains present or after prior laser treatment. Now, there's some UVF imaging is also is something that we can turn to in a case of CRVO. UVF imaging is very helpful to calculate the ischemic index, which is actually the ratio of the non-perfused area to the perfused area, or the ratio of non-perfused area to the total retinal area, because the extent of retinal non-perfusion appears to correlate with the likelihood of neovascularization. In one study, the mean ischemic index among 15 eyes with neovascularization was 75%, whereas the eyes without neovascularization had a mean ischemic index of only 6%. So it's very important that we know how much non-perfused area is there in a case of CRVO. And UVF imaging is a very helpful modality in that scenario. Now, Octa is another investigative modality that we can use in comparison to fluorescein angiography. Octa is a fast, non-invasive, and allows improved and accurate visualization of microvascular changes due to the absence of leakage and tissue staining and better penetration of the longer wavelengths used in Octa through intraretinal hemorrhage. Octa allows better visualization of the microvascular abnormalities in retinal venous occlusions, including neovascular fronts, foveolar vascular zone, and other microvascular abnormalities. Now, these are some of the characteristic things that we can see in the case of CRVO. When we use Octa, we can see whether there are non-perfusion areas. We can see the vascular tortuosity. We can see collateral. We can visualize collateral vessel formation. We can see the disruption of perifoveal capillary plexus, dilatation of capillary plexus, and venous dilation. As we can see in this picture, the general there's a general sparsely the whole capillary CNP area. So we can see the general CNP areas, and we can see the enlargement of the foveolar vascular zone. We can also see that the whole vascular density is decreased. So this is something that we can achieve from an Octa scan. So in conclusion, we go for the etiological workup only in a case of young patient or when he has a thrombotic disease or something. We don't over-investigate a patient who has got known risk factors and who's over the age of 50 or 60. Then we use OCT. We get an OCT done, which is the basis of all the treatment regimen. We decide on whether we have to inject or not based on the OCT findings. Then we can use FFA to quantify CNP areas and to see whether he has a risk of neovascularization. And we can also use ultra-wide fundus imaging to calculate the ischemic index or to see generally whether he has a tendency to go towards neovascularization glaucoma, neovascular glaucoma, something like that. And we can also get an Octa done, which is better than FFA, but it has its own limitations. Thank you.
Thank you, Dr. Gautam. Thank you for your excellent presentation. And Dr. Subhash, sir.
Excellent presentation. Though one message should be clear that to diagnose CRVO, we don't need any investigation. This is the purely clinical diagnosis that has to be made. These investigations are done basically to rule out any etiological factors and to plan the treatment. And he has very well documented everything and has elucidated each and every point. So nice presentation.
Very.
Just wanted to make a small suggestion. I just wanted to share a case of an elderly female patient I'm treating, hypertensive. She came with scattered hemorrhages all over the fundus, not classically, but blood and thunder. Vision was very poor, counting finger 3 meter. And I diagnosed her to be ischemic CRVO. There was macular fluid on OCT. I gave her anti-VEGF, but to my surprise, the vision didn't improve at all. It just remained counting finger 2 meters. And I just wanted to highlight the importance of FFA in such cases and OCTA. OCTA could very well document those sparse areas of, capillary flow, lot of capillary non-perfusion areas in the macula. And that is when you can talk to the patient that, you will not get back very good vision. So OCTA and FFA then become very important in these cases. Although I agree with Dr. Subhash that initially in ischemic CRVO, we don't need to do any investigations. It's just a clinical diagnosis. But this was a very different presentation which I had, and the results were not very, very overwhelming because of the capillary non-perfusion.
No,
thank you.
Yeah, I agree with Dr. Pooja. Angiography is a wonderful tool in seeing the macular ischemia, which you don't able to see on fluorescein in angiography. and you can prognosticate your patient accordingly whether the vision is likely to improve despite resolution of edema or not.
Yes. Congratulations, Dr. Gautam, for your presentation. Just a little, I want to know which investigation, when to advise which investigation. Just OCT, I think it's universally accepted, and we can guide your treatment plan accordingly. So which investigation do now this patient require FFA, now this patient require IOTA, kind of thing. So could you throw a light on it a little bit?
So I don't think so. OCT is FFA is required in the first visit when the patient visits for the first time. Only OCT is required to document whether there's any macular edema or not, because that is how we are going to plan injections for him. If the patient comes for the second time, first month, end of the first month, second month, third month, then we can maybe get a FFA done to get a sense of what is going on around the periphery, to see whether there are any capillary CNP areas are there or not, so that we can predict whether he is going to go for a non-ischemic CRVO, or maybe he could do a neovascular glaucoma kind of a thing.
Okay. Thank you. Thanks.
Initially, you have a lot of hemorrhages, so angiography won't give any information due to blocked fluorescence. And
yes,
yeah,
I think that is rightly said. Initially, FFA will, the capillary non-perfusion will be blocked by the retinal hemorrhages, the blocked fluorescence because of that. So in the initial, if at all, when I see the patient in the acute phase, I would probably just do serial fundus photographs, because that is easy to show the patient, explain to the patient how, whether it's improving or it's worsening. I will do OCTs, because that will OCT and vision, whether they are correlating or not. And maybe after 2 or 3 months, if the visual acuity is not correlating with the improvement I see, because the retinal hemorrhages will improve, let's say, but the visual acuity is not improving. So that will be one indication for me to do an FFA and see whether there is macular ischemia, which explains why the visual acuity has not improved while the retinal hemorrhages have cleared up. So in these scenarios, I would probably do an FFA. If in a case of branch vein occlusion, if I'm looking at a small area which is looking at neovascularization and I'm not sure, then I would do an FFA after 2 or 3 months. So these are some specific indications where I'll reserve FFA for. Now, I think with OCTA, probably even these indications will become obsolete, because you can very well see the neovascularization of a BRVO on OCTA. You can see the neovascularization of a disc on OCTA. You can see the capillary non-perfusion very well. So the question mark becomes then why FFA at all if OCTA is telling you all these things? So I think sooner or later, probably our approach is going to change.
Okay.
Thank you, sir. Thank you for this nice discussion. Dr. Arvind, are you ready with your presentation or video?
Yes, sir.
Okay.
Just. Pardon. बहुत मेहनत किया है बच्चा लोग, सर मौका मिलना चाहिए।
बिल्कुल, that's why we are waiting.
Pritam, a couple of more minutes.
Yeah. Oh yes. I'm enjoying, thoroughly enjoying.
Sir, this video nicely presents the pathogenesis of CRVO. Close relation exists between RT and vein. Central retinal artery bring the oxygenated blood to the retina, and
video is not playing.
Video is not playing. Arvind.
Yes, sir.
इसको play करें, yes.
Yeah, now playing.
Yeah.
Sir, now playing.
Yeah. Just.
So this video nicely presents the pathogenesis of CRVO.
रुक गया फिर, वेनस स्टेसिस हो गया।
डॉक्टर अरविंद, आप अपना वीडियो ऑफ कर दीजिए, तब थोड़ा कम बैंडविड्थ यूज होगा।
Okay, sir.
Yes. Now,
artery bring the blood to the retina, and the vein drain the blood outside the retina. If any arterial hardening if any arterial hardening, it causes the compression of the vein, because both are so close to each other in a narrow space. If the clot is formed, it can obstruct the flow of the blood, and insufficient supply of blood to the retina. Due to insufficient supply of blood to retina, there is a release of a substance called vascular endothelial growth factor, which stimulate the growth of tiny weak blood vessel throughout the eye. These new blood vessels are also at risk of the hemorrhage and other complications such as the neovascular glaucoma. In its earlier stage, a vein occlusion can cause vessels into the back of eye to become dilated and tortuous. As the pressure increases in the blocked vein, and if the pressure gets high enough, vessel wall can rupture and blood can leak into the retina. Blood leak inside the outer plexiform layer and the inner nuclear layers. In addition to the leaking of blood, there is a seeping of the small protein and the lipid also occur. This resulting leak can lead to the macular edema and causes the visual deterioration and the visual loss. Thank you, sir.
Thank you, Dr. Arvind, for your very nice presentation. And now I would like to hand over the proceedings.
Thank you, sir, for giving me the opportunity, sir, next time.
Thank you.
Most welcome, Dr. Arvind. Nothing. Very good. Very good. You have done ultimately well. No.
Very good presentation. Very good presentation. Now I would like to hand over the proceedings to Chairman ARC, Dr. Nagendra Prasad, sir. Thank you,
Thanks.
sir. Thank you.
Thank Asif for moderating the session very well. Now I request upon Dr. Shivani Sinha, who is going to moderate the next session. And over to you, Dr. Shivani.
Thank you, sir. Good evening, everybody. This brings us to our session 2 of the BOSS ARC meet. I invite upon the chairpersons for this session, Dr. Vibhuti sir, Dr. Sudhir Kumar sir, Dr. Salabh Sinha sir, and Dr. Satyaprakash Tiwari sir. And also the panelists for the session, Dr. Pooja ma'am, Dr. Abhishek Kedia sir, Dr. Siddharth, and Dr. Santosh. I would like to request Dr. Satyajit sir to introduce our keynote speaker, Dr. Preetam Samant from Mumbai, who will be speaking on retinal vein occlusion, a journey in time. Over to you, sir.
Thank you so much, Dr. Shivani. It's an absolute honor and privilege for me to introduce one of the topmost vitreoretinal surgeons of India, Dr. Preetam Samant, who is in Mumbai. At present, he is the president of the Maharashtra Ophthalmological Society, and he is an alumni of Shankar Nethralaya, Chennai, an institution from where many stalwarts have come out. Today, Dr. Preetam Samant is an institution in himself, and he is doing some yeoman work in Mumbai. Above all, he is an amazing human being, and I fall short of words to describe him. But at this point of time, for paucity of time, I'll just go ahead and introduce him. He is a senior vitreoretinal consultant at Mumbai, and he will be talking on managing retinal vein occlusion, a journey in time. And this is the sessions 2 keynote address by Dr. Preetam Samant. Dr. Preetam Samant, please. You are muted, Preetam.
Can you hear me?
Yes, now.
Yeah, thank you so much for such a kind introduction. It is always a pleasure to be here in front of you all, Bihar Ophthalmological Society. I think I have very fond memories from the 2019 conference, which Dr. Satyajit had invited me. Both me and my wife, Dr. Himalani, were there, and we had a wonderful time in Patna. Our association with Dr. Satyajit and Dr. Pooja goes back to our alumnus, that is Shankar Nethralaya, from where we've learned all such wonderful things that all of us are doing in medical and surgical retina. So I would like to start my talk. The talk is the treatment for retinal vein occlusions. In the ever evolving medical field, we've seen so many times that what we feel is great and successful today suddenly changes hands, and tomorrow there is something else which comes better. So we'll see how the treatment of CRVO has evolved over time. Can you see my slides?
Yes.
Yeah. Yes. So when we talk about treatment of CRVO, we are essentially looking at 3 pillars. Number 1 is my slide moving to the next one?
Yes, we can see a blue slide with 3 pillars, macular edema.
So the first one is macular edema, treating the macular edema, which is the main focus. because treating the macular edema means improving vision. And we know that macular edema results into permanent retinal damage and photoreceptor loss and vision loss. So this is the first pillar of treating CRVO. The next pillar is when the CRVO becomes a neovascular disease. Now we know that 1 out of every 5 non-ischemic CRVOs will eventually go into an ischemic CRVO and develop neovascularization either of the posterior segment or anterior segment, and then go into neovascular glaucoma. So the second pillar is treating the neovascular component, and the third pillar is treating the systemic association. Now, over the years and decades, we found various etiopathogenetic causes for a CRVO. They are all listed in this slide, and there are some more. And we are and it is evolving. It is ever evolving. Now, in the last 2 years, there were so many case reports of CRVO following COVID, because COVID itself caused the thromboembolic changes, dynamic changes in the blood dynamics, and that led to all these venous occlusive and arterial occlusive diseases of the eye. So there will be systemic associations which we have to take care while we are simultaneously treating the disease. Now, the first really path-breaking work which was done in the management of CRVO was the central vein occlusion study way back in the late 80s and 90s. And what they tried to study is, the laser had just come into vogue for the past 2 decades, and everyone was keen to treat the macular edema in central retinal vein occlusion with laser. So they decided to see whether, the laser versus the control eyes which nothing was done versus laser, was there any difference? To their amazement, they found, if you see, look at the orange line and the blue line, that the eyes which were treated with laser hardly really showed any improvement as compared to the control eyes. If you look at this table, if you see, the first column is a laser treated eyes and the second is a control. Now, if you look at the macular edema, okay, macular edema did go down a little bit, but the visual acuity, the functional parameters, there was hardly any difference between the 2 arms, that is a laser treated and the control arms. So the CVO study concluded that grid laser photocoagulation, which was so useful for diabetic macular edema and branch vein occlusion, was not useful for improving vision in central retinal vein occlusion. The other thing which this study tried to research is the use of pan-retinal photocoagulation when the CRVO, the disease, turns neovascular. So when there is anterior segment neovascularization and neovascularization of the disc, what happens? Does pan-retinal photocoagulation helps? And the study found that PRP, or laser photocoagulation, was useful in preventing these eyes into going into neovascular glaucoma. So when they came out with the results in the 90s, they said that while grid laser photocoagulation is not useful for macular edema, the pan-retinal photocoagulation was definitely useful to prevent the neovascular glaucoma, and therefore the eye going painful and blind. So these were really some landmark judgments. And then following I remember in the late 90s, when we were doing our fellowships at Shankar Netralaya, we were following these criteria given by the CVO study for quite a few years, until finally what came in was the intravitreal pharmacotherapy. With the advent of intravitreal pharmacotherapy, I think the whole game changed, because here now we could actually think about improving vision in cases of central retinal vein occlusion. The rationale for the intravitreal pharmacotherapy was, in the pathophysiology, we know there is an overexpression of VEGF in the retinal vein occlusion, and hence anti-VEGF therapies are effective in reducing the macular edema in various other retinal diseases, and hence they can be applied here also. One of the first really intravitreal agent which was available to us was triamcinolone. So the SCORE CRVO study tried to compare the use of triamcinolone in CRVO versus just observation, like what they had done in CVO study. In CVO, they had compared laser and observation. This study was comparing triamcinolone and observation. And with triamcinolone, they chose 2 concentration, the 1 milligram and the 4 milligram. And what they observed was that triamcinolone was very, very effective in bringing down the macular edema over the first 12-month period. The only concern with steroid, as we know, was the glaucoma, secondary glaucoma which occurred, and hence, but that's why they had chosen 2 doses, and they saw that with 4 milligram, the IOP rise was much higher as compared to 1 milligram. One very effective thing which a subgroup analysis which they made was that the triamcinolone was not only improving vision by decreasing the retinal edema, but it was more of its anti-inflammatory and neuroprotective effect which was helping the vision to stabilize or improve. So this was very important thing which they observed. Of course, like I said, the advantages were it helped in improving the vision, improving the macular edema, but the disadvantages was that again it had a half-life. You had to repeat it maybe after about 2 months, 3 months, or 4 months. The raise in intraocular pressure was a problem, and cataract progression was a problem. So these were the downsides of triamcinolone. Finally, the anti-VEGFs came into vogue in the early 2000s. We had the anti-VEGFs, and the anti-VEGFs again changed the ball game. The landmark study done by Novartis was the use of ranibizumab in central retinal vein occlusion. It is called as the CRUISE study. The counterpart of CRUISE study for BRVO is the BRAVO study. The CRUISE study showed, as you can see over here, that following this is 6-month results, you can see that almost 15 letter improvement, a mean gain of visual acuity of 15 letters after using ranibizumab intravitreal injection in CRVO. This was something phenomenal, we never heard of with the treatments before. And you can see over the percentage over here, those injected with 0.5 milligrams, almost half of the patients had more than 15 letter gain. So these were phenomenal results. But mind you, again, what were the advantages and the disadvantages? Of course, the advantages was vision improved, macular edema went down. It was generally well tolerated. That means no secondary glaucoma, no cataract. But disadvantage, monthly dosing. Mind you, in this trial itself, in CRUISE trial, it was given every month for first 6 months. So that was almost 6 injections every month, 6 months. So it turned out to be a very expensive proposition, and nobody really knew what was the optimal dose regimen in retinal vein occlusion. Then there was the poor man's anti-VEGF, that is Avastin, bevacizumab. In 2005, we know, after Dr. Rosenfeld used bevacizumab, everything changed. People all over the world started using it, although it was off-label. And there were so many anecdotal and retrospective studies which showed that in CRVO, almost 3 lines improved in the first few weeks, in the first few months. But then as time progressed, when the disease became 2 years old, that 3-line improvement slipped to about 1.5 line improvement. But nevertheless, it was a good alternative to situations where you could not use ranibizumab. Here's a typical scenario where you have a CRVO, an ischemic CRVO with a macular edema like this, and 3 injections of bevacizumab over a period of 3 to 4 months gives you this kind of a result. No edema, you can see all the retinal hemorrhages absorbed and the foveal contour restored, with improvement in vision. Then after this, again, steroid came back. And how did it come back? It came back in the form of this particular steroid implant by Allergan. So here was an implant which was essentially a polymer in which dexamethasone was infused, and that once you injected it into the eye, it slowly released over a period of time. So here the Geneva study was a path-breaking study. In fact, it was their maiden study in CRVO, the Geneva study, which showed, as you can see over here in vein occlusion, the 60 days following the injection, that is 2 months, there was a phenomenal almost 10 letter gain in vision due to the reduction in the macular edema. But again, the downside was, as the time went by, the edema seemed to again come up, and the improvement in vision seemed to again go down. As you can see over here, the edema went down by day 90. There was so much reduction in macular edema, whereas by 6 months, that macular edema seemed to creep back. So everything has its half-life, and so did Ozurdex. Here's a typical case scenario. There's a 40-year-old woman, the CRVO of a young patient, as we call it, and you can see over here the macular edema. And this is 23rd Jan. After giving 1 Ozurdex, after a week, you can see the edema resolving, and 2 weeks later, the foveal contour is restored. This is 2 weeks following the first injection of Ozurdex. Now, you would think, I've given it on 23rd Jan, so maybe 5-6 months, everything will be okay. But look at this picture of the same patient. By 5th of May, the patient was back for another Ozurdex, needed another Ozurdex because his edema had come back. So, even with this particular implant also, there were downsides. The downsides, of course, were not as much as triamcinolone, because the incidence of cataract and the glaucoma was much less with the Ozurdex implant. But there were other concerns like any other intravitreal injection with Ozurdex also. Then nowadays, in the last couple of years, we have had aflibercept, which has also been used in CRVO. There have again been some path-breaking research, the Copernicus and the Galileo studies, which compared aflibercept versus sham injection or controls, again showed phenomenal results where most patients gained more than 15 letters within 24 weeks. Within the first 6 months, there was 15-letter gain, pretty similar to the cruise trial of ranibizumab. So this is another anti-VEGF now, which we have in our armamentarium. You can see over here fantastic results. 70% of the patients, as ranibizumab, remember it was 50%. Here 70% are showing 15-letter gain. So as new and new anti-VEGFs come, I'm sure we'll be seeing much better results in CRVO. Then came the biosimilars. So once the patent of the drugs got over, all other companies jumped into the competition, into the race, and now we have all these 3-4 biosimilars which are also giving fantastic results, and more importantly, they are pocket friendly, because the economics become better with these biosimilars, and more importantly, the stress of using off labels seems to have gone down. I have most of my Avastins or Zaltraps now. I know I can give some of these biosimilars because the patient can afford it. That brings us to another concept now, and when and how many dosing. So this also has evolved over time. So we have the 3 concepts. I'm sure some of our speakers will be going into details on this later on, but we have the concept of loading dose, where we give injections for first 3 months every month. Then we have the concept of maintenance dose, which is either a PRN dosing or a treat and extend dosing. And of course, we look at various biomarkers, like most important biomarker being the visual acuity, the gain of how many letters of vision. That tells us whether we keep on injecting or not. And the other biomarker is the central retinal thickness, which tells us whether we should keep injecting and how many injections. Of course, one must remember that the treatment should not be a burden to the patient, and we still have a lot of mileage to cover in terms of the insurance supporting the patients. Not all the injections are covered in insurance, and it can be sometimes pretty messy when the patient deals with the insurance. We all know that. Surgical options for central retinal vein occlusions. Now, there are so many medical retina diseases which have had which we try surgical options. One of them was radial optic neurotomy, which showed some promise when it came in vogue. But once the results of large studies came out, it didn't turn out to be. It didn't really stand the test of time. And I really don't think anybody now does it on a regular basis. But this is a video of one of the cases which I had done, where essentially you do a good vitrectomy, you induce a PVD, and what you do is you plunge your MVR blade right into the matter of the optic disc there. The rationale being, just like Dr. Arvind mentioned in the pathophysiology, that it is this ring of lamina cribrosa, which is like a noose, which is causing the vein occlusion. So the concept here is you release this particular noose, and hopefully you allow the blood flow to improve. So you plunge the MVR blade. Of course, you have to raise the bottle height. As you can see, the disc has blanched because I've raised the bottle height, and I'm doing this because I don't want a lot of bleeding from the optic disc. You plunge the MVR blade and you take it out in a radial fashion. There you can see a small nick. Luckily, it has not bled from this point. And I used to follow the 2 nick technique. I've done it one over here, and I'll do it somewhere on the superior aspect. So I'm plunging it again into the margin of the optic disc. There it is, the MVR blade going into the disc. It's a little horrifying to look at it. And then you bring it out again. And then you slowly decrease the bottle height and pray that the disc doesn't bleed out. You can see, you might be able to see an ooze from one of them. Yeah, there is a little ooze from here when I decrease the bottle height, but more or less it has stayed as it is. Frankly, in my hands, I was not really impressed by the success of radial optic neurotomy. Then there was, people tried transvitreal vein cannulation, where you again go do a vitrectomy and you try to inject a TPA into one of the branches of the retinal vein, with the rationale that TPA will dissolve the clot and improve the blood flow. Then there was another technique called as a laser chorioretinal venous anastomosis, where here the rationale was to create a huge bypass to break the Brooks membrane and create a bypass from a large retinal vein into the choroid. So you use a very high energy laser pulses at the branching of at the branching of at a AV nicking, and you hope that it will create a conduit from the retinal vein into the choroid. Again, there are anecdotal reports about this technique, but I don't think this is really in vogue now. So these were some of the treatments. Of course, we should not forget CRVO with neovascular glaucoma. So when it comes to neovascular glaucoma, we all know we have to treat the glaucoma, do the pan-retinal photocoagulation, and decrease the ischemia which is there in the retina. And the glaucoma might require treatment in the form of cyclocryo or diode CTC. If there is vitrectomy, then we have to do, if there is vitreous hemorrhage, then that will require vitrectomy. One important thing which has stood the test of time, before I conclude, is OCT. I think Dr. Gaurav did a fantastic presentation to show all the investigative modalities. But OCT is something which is very cardinal when you're dealing with an acute CRVO. It helps us to quantitate the macular edema, becomes a very easy tool for follow-up. And there are other concomitant pathologies like ERMs, vitreomacular traction, lamellar macular holes, which you can pick up on OCT. One important thing, landmark thing now, is the OCT angiography, which I personally believe is a game changer and probably might make FFA obsolete, because it will help us study the capillary perfusion and help us in decision making and prognosticating the disease. So this is my second last slide. So where do we stand finally? So I would like to conclude by saying that the treatments that we have so far for CRVO are essentially anti-VEGF steroid injections and laser for the neovascular stage of CRVO. So these are the two things that we have in our armamentarium now, which we have to use for treating CRVO. My approach is to start treating in the acute stage without wasting any time, because the more you let the macular edema stay, the more the vision is going to drop. So reduce the macular edema for visual gain. The anti-VEGFs will decrease the capillary non-perfusion also, and hence it will decrease the risk of progression of the ischemic disease. And if I find that the macular edema is progressing beyond 6 months, then sometimes switch over to a steroid like Ozurdex, which will give a long-term effect and probably help in the longer phase of the disease. And last but not the least, use laser when there is a neovascular component. So with that, I would like to thank again everyone for their patient listening.
Thank you so much, Dr. Preetham, for that wonderful presentation. You have covered the entire management so nicely. It was a very, very wonderful presentation. Thank you so much for your time and presentation once again. I'd like to request Dr. Shivani to continue with the session, please.
Thank you, sir, for the wonderful presentation. And can we have a quick one comment from the panelist?
Yes. Hello, this is Dr. Santosh. Sir, actually, I want to ask one question from Dr. Preetham Samant, sir. So that was a great presentation, sir. Many things to learn from that. Sir, I want to ask that in CRVO, which included mostly acute cases, and monthly injections was given for first 6 months, which we are like hardly following in clinical practice. And after the follow-up study of CRVO in Horizon and Retain, we got a group of patients who were like non-responders or partially responders. So, sir, practically, like, can we detect these partial responders earliest and switch to other injections if it is not working? After how many injections do you prefer to switch to other anti-VEGFs or to steroids?
Like I mentioned, the two most important biomarkers will be the macular edema, the central retinal thickness, and the vision. Now I usually follow the loading dose, that is monthly 3 injections, and then I immediately switch the patient to treat and extend, because I found that with treat and extend, the number of visits the patient has to make comes down. And with treat and extend, the patient feels as if we are tailoring the treatment for the patient. Many times you keep injecting every month, the patient sometimes loses hope, loses patience. So I usually use the loading dose and the treat and extend. If there is a situation where I am stuck now that a particular, after 6 months, the edema is not settling, and it keeps coming back after every monthly or 2 monthly injections, then probably 6 months, after 6 months from the acute stage, I will either switch over to another anti-VEGF or then switch over to Ozurdex. So that is the protocol I follow. I would like to ask Neeraj. Neeraj is over here. Neeraj, what is your protocol for CRVOs? Because this is a very important question. I think you asked.
Correct. Actually, Preetham, in our Indian scenario, we cannot afford to give patients indefinite injection for 6 months or 1 year. So the treatment protocol I also follow is giving 3 loading intravitreal injections of anti-VEGF, and then giving treat and extend therapy. And if the patient is willing for regular checkup every month, then I take PRN therapy also. But now more and more patients in CRVO, BRVO, or even DME, so we are giving this treat and extend therapy to reduce the number of injections for them and reduce the financial load, and also lessening the trauma of giving intravitreal injection for the patient. And but one more thing I've seen, like all these patients, they need to be kept for a longer period of follow-up, because the chances of capillary non-perfusion in CRVO, it increases over a period of time, and all the patients, they need to check without dilated pupil, without any rubiosis, because we are not able to pick up sometimes the capillary non-perfusion on indirect ophthalmoscopy, but at least this NVI or rubiosis can be picked up well in time. And all these patients, when the retinal hemorrhages reduces, we should do OCTA, especially to rule out any macular ischemia, which is picked up well on OCTA rather than fundus fluorescein angiography. And FFA we can use for to rule out any peripheral capillary non-perfusion or any neovascularization.
Yeah. Just one suggestion for all the PGs here, that sometimes even when the patient comes, they straight away dilate the patient to see the fundus. First, do the undilated examination of the iris to see whether there is any neovascularization or not. Then you dilate, and so that you can't miss any neovascularization. That is one message I wanted to give. And any experience of using Pigenex, Dr. Preetham or Dr. Neeraj?
Yeah. So I didn't include it in my presentation, but I think Pigenex is another important, which has just come out about a year ago. Although Pigenex is still not got FDA approval for CRVO, they are trying for one, and it might come in a month or 2. But I have done a couple of cases, and I think it is definitely not inferior to the Eylea or the ranibizumab results. It is equally good.
Yeah, sir, I think it is equally good. Even this bevacizumab is equally good, sir. Even the clinical trial also showed, if you compare aflibercept with bevacizumab, it is non-inferior to.
Absolutely. Bevacizumab, or for that matter, Zaltrap also.
According to Swansky, not doing anything is also good.
Just one more point I'd like to make. Because here, we are always looking at the capillary non-perfusion, the peripheral capillary non-perfusion. So, if I have a situation where at 6 months, I'm not really happy with the way the edema is going, then I would do an FFA to look at the peripheral capillary non-perfusion. But, there was a school of thought which said that if you laser the capillary non-perfusion areas, then maybe your need for injection would go down. But I think there is now enough literature. In fact, I think the Chandigarh group has present literature, and there is literature from the West also, which says that doing PRP does not really reduce the number of injections. Doing PRP would probably reduce the incidence of neovascular glaucoma, but not the number of injections. So that point I thought I'll make.
Do you think that is true in Indian scenario as well, Dr. Preetham and Dr. Neeraj?
Frankly, I was hoping that the result would come otherwise, because if by doing PRP to the peripheral non-perfusion areas, the VEGF load would come down, then it is logical to say that the number of injections would reduce. So I myself, I find this data surprising.
Do we take it with a pinch of salt?
We do laser in a
For the
very
benefit
limited
of the
number of cases.
postgraduate, just wanted to ask, is there any association of CRVO with primary open angle glaucoma?
So
Can you repeat, please?
Is there any association of ischemic CRVO with primary open angle glaucoma? Because sometimes we see a lot of optic disc cupping in these cases, and there are that there could be a glaucoma link. Do we look
No, I have
into
seen a lot of cases.
Absolutely. So one of the local risk factors is supposed to be primary open angle glaucoma. So I'm sure if you have a case of CRVO, I think you have to give that look from that angle also, and you might have to treat that and probably make sure that the other eye is not at risk for developing the same changes.
In fact, in CRVO patient, pressure goes down initially. So you have to look other eye to whether patient is actually having glaucoma or not.
So for that matter, even if you don't have any changes of glaucoma in the other eye, if the pressure is high enough, then we should start giving anti-glaucoma medicines in those patients to prevent occurrence of CRVO in other eye. That's the one suggestion.
Anyway, very excellent presentation, Dr. Pritam Samant. Totally engrossed in your presentation. So I think we are running late. I will move on to next presentation, Dr. Shivani.
Yes, sir. We will move on to the next presentation on differential diagnosis of CRVO and risk factors by Dr. Harish Shilango. Dr. Harish is a final year postgraduate student from DMCH, Darbhanga, and has done his MBBS from Sri Ramchandra University, Chennai. Over to Dr. Harish.
Thank you, ma'am. Thank you so much. Very good evening to all the esteemed teachers, chairpersons, panelists present. I would like to thank this. I would like to begin by thanking Chairman Sir, Nagendra Prasad Sir, for giving me this opportunity. Today, my topic is on differential diagnosis and differential diagnosis and risk factors of central retinal vein occlusion. The first differential diagnosis I would like to talk about is hypertensive retinopathy, the most commonly associated one. Then diabetic retinopathy, ocular ischemic syndrome, retinopathy related to blood dysplasias, human immunodeficiency virus retinopathy, and giant cell arteritis. Hypertensive retinopathy is usually a bilateral disease, and the acute hypertensive retinopathy with disc edema may appear clinically similar to bilateral central retinal vein occlusion. In this picture on the left, it's a picture of a right eye fundus, which shows attenuated arteries and superficial flame-shaped hemorrhages and cottonwool spots. And on the picture on the right is a right eye fundus showing central retinal vein occlusion with cottonwool spots and disc edema. And diabetic retinopathy is also a bilateral disease, and it requires concurrent diagnosis of diabetes, and the veins can become dilated and tortuous as disease progresses. Fundus shows dot and dot hemorrhages more in posterior pole, and hard X-rays are major finding in diabetic retinopathy, and cottonwool spots are seen, and optic disc is affected in papillopathy. In this picture, you can see the hard X-rays over here, and dot and dot hemorrhages. And this is a picture of central retinal vein occlusion. The third differential diagnosis is ocular ischemic syndrome. There is a sudden vision loss in 12% of cases, and the majority of lose their vision over a period of 2 to 3 weeks. Usually unilateral presentation, but could be bilateral in 20% of cases. And it's a painful condition, and hence it's called as ocular angina. And fundus shows attenuated arteries, dilated and beaded veins. And it can additionally can have choroidal non-perfusion in addition to retinal non-perfusion, and it's also associated with hypotony due to ciliary body ischemia, and retinal hemorrhages seen in periphery instead of global picture as in central retinal vein occlusion, and there are no hard exudates or no disc edema and no cottonwool spots. The picture on the left is a picture left eye fundus, which shows dilated arteries and dilated veins and attenuated arteries with the dot and blot hemorrhages in the periphery and mid-periphery. This is a tabular column which compares ocular ischemic syndrome, central retinal occlusion, diabetic retinopathy. The main important features: the venous condition is dilated and beaded in ocular ischemic syndrome, and central retinal occlusion is dilated and tortuous, and again in diabetic retinopathy is dilated and beaded. And an optic disc is involved or swollen in central retinal occlusion, whereas it is normal in ocular ischemic syndrome, and it is affected in papillopathy. And the retinal artery perfusion is decreased in ocular ischemic syndrome, and it is normal in central retinal occlusion. It's also normal in diabetic retinopathy. And retinopathy is related to blood dyscrasias. For example, in severe anemia with thrombocytopenia is a bilateral condition, and it resembles central retinal occlusion sometimes due to the hemorrhages, which are well defined and well clear cut. And you can see the rod spots on the hemorrhages, which are nothing but filling deposition. And this pallor is also seen. And the human immunodeficiency virus retinopathy, it could be unilateral or bilateral, and the vascular architecture is preserved. And the most common corneal spots are other corneal spots and other non-infectious retinopathies. And there is no dyskidemia. And the last differential diagnosis I would like to talk about is chain cell arteritis. It presents as anti-ischemic optic neuropathy, and it shows resemblance due to the edematous disc and the peripapillary flame-shaped hemorrhages and the surface telangiectatic cells. The risk factors and associations. The broad classification includes systemic vascular disease, mainly consisting of diabetes and hypertension, and the ocular diseases mainly associated with ocular hypertension and primary open-angle glaucoma, and other hematological alterations and autoimmune vasculitis. Medications, mainly oral contraceptions, and infectious vasculitis and external compression of globe and optic nerves from thyroid-induced ophthalmopathy could also be a risk factor. And other risk factors include retrobulbar block, dehydration, pregnancy, Valsalva, and head trauma with orbital fracture. In systemic risk factors, the first I would like to compare, I would like to mention the risks involved in arterial hypertension and diabetes mellitus and hyperlipidemia. In this article on the left from May 1996 from Journal of American Medical Association, it shows increased risk with hypertension, diabetes, and open-angle glaucoma. Physical activity and alcohol consumption decreases risk. And the article on the right from from August 2009 from Journal of Thrombosis and Thrombolysis shows hypertension as a more frequently involved in CRVO patients to 64.9% when compared to 28.2% in controls. And diabetes is said to be present in CRVO patients of 17.9% and compared to 7.9% in controls. In this study from February 2013, published in American Academy of Ophthalmology, shows hypertensives and diabetics with end organ damage have a 92% and 53% respectively increased risk of CRVO compared to those without. And the diagnosis of stroke increased the risk of CRVO by 44%. In the study from May 2008, published in the Journal of American Medical Association, shows hypertension and CRVO again to be almost 50%, and hyperlipidemia also is said to be a major risk factor comprising 20%. And ocular risk factors, the main ocular risk factor I would like to talk about is ocular hypertension and glaucoma. In this article from January 2004 from American Academy of Ophthalmology, we can see the prevalence of ocular hypertension and the primary open-angle glaucoma in CRVO patients, 16.2% and 9.9% respectively. Rheological other risk factors, mainly rheological abnormalities, increased hematocrit, increased plasma viscosity, increased red cell aggregation, and reduced red cell deformability. And thrombophilia, including hyperhomocystinemia, antiphospholipid antibody syndrome, increased activated protein C resistance or factor V Leiden mutation in young patients, reduced plasminogen activated inhibitor, oral contraceptives, and other risk factors in hyperrespiratory syndromes like polycythemia, macroglobulinemia, myeloma, and leukemia. And inflammatory diseases with occlusive peripheritis, for example, Behçet syndrome, dark idosis, and vaginous granulomatosis. And last, the other risk factors I would like to talk about retrobulbar, dehydration, Valsalva, and pregnancy. Thank you.
Thank you, Dr. Harish. It was such a nice deliberation on the differential diagnosis. We can have the questions at the end of the session. Now I invite Dr. Shishir Shekhar Singh on his talk on role of lasers in treatment of CRVO, which is a very relevant topic. Dr. Shishir is an alumnus from the prestigious St. GS Medical College and KEM Hospital, Mumbai, and has completed his MS Ophthalmology from RIO, Kolkata, and his VR fellowship from Dr. Nagpal's Retina Foundation from Ahmedabad. And he is currently working as a VR and phaco surgeon at ASGI Hospital, Patna. Over to you, Dr. Shishir.
I'll share my screen. Is my screen shared? Is it visible?
You are visible. The screen is visible.
Yeah. Why it is?
Yeah. Good evening, everyone. Thank you so much to BOS for giving me this opportunity, Dr. Nagendra sir, for giving this opportunity for me to talk on this topic. I'll be speaking about lasers in the treatment of CRVO, the role of lasers in CRVO. In CRVO, the causes of vision drop that need to be tackled, which has already been discussed by Dr. Samant sir, most important being macular edema, and the second being neovascularization and its complications. In macular edema, we know that there is no or hardly any limited role of laser. At least there is no direct role of laser by a macular laser for macular edema treatment. For neovascularization, there is definite role of PRP. However, the definite guidelines, there is no definite guideline regarding the exact indication and timing of PRP when it should be done in the case of CRVO. CVOS was a National Eye Institute sponsored study. And according to this study, they showed that PRP has to be done after development of iris neovascularization. But there was also a note that provided patients can visit and have a frequent follow-up for fundus examination, which can sometimes be a difficult situation in our country where the follow-up, the patient compliance cannot be completely relied upon on all practical purposes. There will be patients who will be willing to follow up frequently, but it is a slightly difficult, tricky situation. CVOS also said that by prophylactic PRP, the risk of iris neovascularization is decreased but not eliminated. So how useful it was before iris neovascularization was doubted. But for practical purposes, if once the iris neovascularization has occurred, there is a high chance of the eye going to neovascular glaucoma, corneal opacity because of raised IOP, and PRP at that stage would be a difficult situation. So I'll be going through two cases to show to highlight the importance of PRP when it can be performed. This is a clear-cut case of CRVO with blood and thunder fundus. The OCT shows macular edema, and FFA, although not very essential at this stage, but done to see the findings, shows blocked fluorescence because of the retinal hemorrhages. There is delayed AV transit time. The periphery also shows blocked fluorescences, no obvious gross, non-perfusion or capillary dropout areas seen. The late phase shows leakage of the disc. So this is a clear-cut non-ischemic CRVO. Such a patient would require only injection treatment based upon the discussion already taken. Anti-VEGFs can be used. No laser is required. And these patients usually do fairly well. Pre and post injection treatment, we see that the macular edema has come down, the hemorrhages have subsided. The early phase FFA, we see pre and post, the hemorrhages we see are decreasing. The late phase FA also, the first two FAs were pre-treatment, where we see the hemorrhages there, disc leakage in the late phase. In the post-treatment, the FFA looks almost like a normal fundus. The hemorrhages have subsided. There is hardly any tortuosity of the vessels seen. The disc leakage present in the late phase has disappeared. So non-ischemic CRVOs with usually good vision at presentation do not need lasers. Injection treatment is sufficient. Yes, but definitely follow-ups even after the treatment has completed will be required. Coming to a second case, we have a case in which we see there are more hemorrhages all around. The disc is more edematous. Some area in the supero-nasal retina clinically also can be made out that it has non-perfusion. The OCT shows macular edema. FFA also done for this patient at this stage, although not very warranted, but documents a late AV transit time, blood fluorescences, and gross areas of capillary dropout can be seen. There are leakage, perivenular leakages almost becoming a neovascularization. The late phase shows massive disc leakage. So this is a clear-cut case of ischemic CRVO, which practically I think should be lasered at some stage. No point waiting for it going into developing neovascularization of the iris, more chances of neovascular glaucoma then, more chances of vitreous hemorrhage then. And in a country like ours, where patients might be finding it difficult to continue with injection treatment, lasers can be an option at this stage in these CRVOs. After a couple of injections or after the first injection, when the patient visits for the second injection, PRP can be attempted. We see the pre-treatment photo, the post-treatment photo with injection and PRP. After 2 years also, the patient has kept stable looking fundus, although this patient, the macular edema had a waxing and waning course. It was an ischemic CRVO. Patient had to be injected multiple anti-VEGFs as well as Ozurdex in between injections, but fairly maintained macula at the end of treatment after 2 years. When we see the changes post-laser in the fundus angiogram, the pre-treatment and FFA shows marked blood fluorescences, non-perfusion area, delayed AV transit. The post-laser treatment angiogram early phase does not show any blood fluorescence. The hemorrhages have subsided. We see decreased hemorrhages. The non-perfusion areas, if well lasered, it definitely reduces the chances of complications of neovascularization, which are most importantly neovascular glaucoma, which is a very difficult situation to treat, which we would not want to land into, and vitreous hemorrhage, which also would need a surgical treatment at many times. So post this laser, we see a dramatic difference in the appearance of the angiogram. The leaky vessels have all subsided. Many times they subside on its own course also in CRVO, but there is no point waiting further beyond this looking FFA to wait for iris neovascularization and neovascular glaucoma to occur to then decide for PRP. I would suggest that we should do a PRP in this case at some stage after anti-VEGF treatments or Ozurdex treatments. The late phase also shows marked reduction in disc leakage. Both the anti-VEGF and PRP treatment done for this case. So for PRP, the settings we use is similar to what we use for any diabetic retinopathy PRP. The Mainster PRP 165-degree lens is used, which has an image magnification of 0.51. Laser spot magnification is 1.96x. We use argon green or frequency doubled Nd:YAG laser. This magnification factor, we can just say that, see, if we use a spot size of say 200 microns, the beam size of 200 microns will give a spot size on the retina of around 210 to 220 microns is what is the calculation that it comes out to be. The spot size to be used is 200 to 500 microns. It will also, the power will also depend upon the spot size used. Lesser the spot size used, lesser the power will be used. Duration is 0.2 seconds. Interval, we can keep 0.2 to 0.1 second depending upon how comfortable we are with the laser. The power used is, there is no fixed rule what power should be used. It should be titrated for a mild white bond, starting from say 150 millivolts to, we can increase it and titrate it to get a mild white bond. Thus, coming to the end, the role of laser, especially PRP, because as you have seen, there is no role of macular laser in CRVO. The role of laser in treatment of CRVO virtually eliminates the severe complications of NVG. It reduces the risk of vitreous hemorrhage. although already discussed that there is no role on macular edema, but indirect effect on macular edema by reducing the metabolic requirement of peripheral non-perfused retina can be thought is there, and it should, in theory at least, help in reduction of macular edema, because it's the peripheral ischemia which is driving the edema. So on theoretical grounds, there should be some help. So for this concept, a targeted laser treatment has come out, that not a complete pan-retinal photocoagulation, but based upon the FFA, a targeted laser to the non-perfused or neovascular areas can be done if you want to preserve the peripheral retina from damage by excess laser. Thus, I would say that laser is definitely the definitive treatment of neovascularization. Anti-VEGFs do help, but laser is going to be the definitive treatment if there is retinal neovascularization in a case of CRVO similar to a diabetic retinopathy. And it's a cheap option for a country like ours, where patients, where an ischemic CRVO patient might not be affording enough to be taking monthly injections. It's a cheap option to at least reduce the risk of vitreous hemorrhage and neovascular glaucoma, which are very serious complications and sometimes even threatening the vision and eye. Thank you.
Thank you, Dr. Sishir, for the very informative talk. This brings us to the last talk by Dr. Neeraj Sanduja sir on latest update in management of CRVO. Dr. Neeraj Sanduja has completed his MBBS and MS in Opthal from Medical College Rohtak. Subsequently, he has done his 3 fellowships from esteemed Shankara Nethralaya, Chennai, and clinical and research fellowship from there, and Sir Ratan Tata Fellowship. He went on to do pediatric retina and ROP training from Michigan, USA. He was also conferred fellowship of Royal College of Surgeons, Glasgow, and has also achieved a certification from ICO, UK, and FRCS, Glasgow, UK. And he's presently working as a chief consultant ophthalmologist and director, Vian Retina Center, Gurgaon, and as a senior consultant at Fortis Memorial Research Institute, Gurgaon. Over to you, sir.
So thank you, Shivani, for your kind introduction. First of all, I would like to thank Dr. Satyajit, my dear friend, for inviting me over to this wonderful session, and Dr. Nagendra Prasad and Dr. Ranjan sir for being a kind host. So I'll be moving on to my presentation with latest update in management of CRVO. Laser management has already been discussed very nicely. So the focus in management of CRVO revolves around managing the systemic predisposing factors, laser photocoagulation, but now the shift has been towards the pharmacotherapy in form of anti-VEGF drugs and steroids. So what is the rationale of using anti-VEGF drugs in retinal vein occlusion? Because the VEGF level is increased, and we have in our armamentarium ranibizumab, aflibercept, and bevacizumab, and various biosimilar drugs. I'll be touching upon some clinical trials, because these trials have given us insight how to use the drugs in our clinical practice and what is their relevance. So the CRUISE trial was comparison of ranibizumab versus sham and ranibizumab versus grid laser in patients of BRVO in form of Bravo study and CRUISE trial for CRVO. And it was seen if you're giving ranibizumab, whether 0.3 milligram or 0.5 milligram, the mean vision change from the baseline was plus 12.7 letters and 14.9 letters in ranibizumab group versus only 0.8 letters improvement in the sham group. So you can see there has been remarkable gain in terms of visual acuity by giving injections. And more than 15 letter gain was seen in almost 46% of the patient in comparison to 16.9% patient in the sham group. If you look at this graph carefully, the same thing, the patient who received ranibizumab, they had consistently better visual acuity 12 months time. And rather, if you compare with sham group, vision was less, but once you started giving injections, the vision improved. But if you delay the treatment, visual acuity gain is not so great if you had started the anti-VEGF treatment right from the beginning. What Dr. Preetham also pointed out, treat the vision with anti-VEGF drugs when the disease is acute. And it was also seen the reduction in central retinal thickness was much more when the patients were given ranibizumab, and it was maximum at day 7. To see the long-term safety and tolerability of ranibizumab drug, horizon study was, the patients were given monthly injection and then they were shifted to the PN regime. And it was seen that long-term usage of ranibizumab was well tolerated, and the patient required longer term of follow-up because to decrease the chances of rubeosis and neovascularization. Retain study was again a long-term follow-up, and interestingly in this study it was seen the number of injections what a CRVO patient gets is 4.5 in year 2, 3.6 in year 3, and 3.3 in year 4. So as the duration of the disease increases, the number of injections they reduce. So what we learned from these studies, that functional outcome was maintained after 4 years of a PRN regime with ranibizumab injection, and there was a reduced number of injections over a period of time. And these patients, they require ranibizumab treatment to decrease the chances of macular edema if you have to give the patient having good vision. SHORE study was to see whether giving monthly injection and PRN treatment of ranibizumab drug, which was more beneficial. It showed that if we are giving the injections on monthly basis or on a PRN basis, the visual outcome was same. So, and the number of injections were approximately half in PRN group. Means you are maintaining the patient's vision at the same level by giving less number of, almost half number of injections rather than treating them on a monthly basis. So as I said, PN regime is basically you're giving less number of injections, and also we should treat the disease at the acute level itself, prompt intravitreal treatment, and subsequently monthly injection till the visual acuity is stable, and then changing the patient to the PRN regime. Copernicus and Galileo study showed the effect of 2 mg aflibercept in cases of macular edema with CRVO, and it showed switching from monthly to PRN regime at 6 months resulted in the same visual gain what you are getting with the monthly. And also the duration of aflibercept drug was little more than ranibizumab. So means that follow-up you need to give less number of injections. And also, if you're giving these injections in a longer term, there was a less tendency for the patient to progress to retinal and iris vascularization compared to the sham group. SCORE 2 study was a comparison of bevacizumab and aflibercept, and it was seen that this drug is also not inferior to aflibercept. Steroids also have been used in CRVO. The rationale is it is not only increased level of VEGF, there are other cytokines also which whose level is also increased. So by suppressing these cytokines, steroids are also be used.
Dr. Neeraj, can you put it in slideshow? We are able to see all the slides.
Sorry. It's okay? Yeah. So the steroids in CRVO, the rationale is to reduce capillary permeability, to inhibit the expression of VEGF gene, and it also has got neuroprotective effect. And also it has been seen to improve the retinal oxygenation with the Ozurdex injection. And we have got 3 steroids, triamcinolone, dexamethasone implant, and fluocinolone implant. SCORE CRVO trial was done to see the efficacy and safety of both 1 mg and 4 mg dose of preservative-free intravitreal triamcinolone. And it was seen that 1 mg is as effective as 4 mg, but with 1 mg, you're less likely to have side effects like cataract and increased intraocular pressure. And in our practice also, we should use only 1 mg of triamcinolone if at all we are using, and if we are not using Ozurdex. Ozurdex Geneva study was also done to see whether visual acuity improvement can be effectively achieved after the second injection at month 6 or not. A Rendex study was done to see the ranibizumab efficacy versus dexamethasone implant, and it was seen that both the drugs are effective. So we have been using primarily anti-VEGF drugs in our patients, But switching to steroid is indicated if you have given two doses of anti-VEGF drug, patient is not responding, then you should shift to steroids. And also as a first-line therapy, steroids can be used when you have a recent history of any major cardiovascular event. Or if the patient is unwilling to come for monthly injection, then you can give them injections because the effect remains at least for 3 months, though they claim for 6 months, but mostly it is 3 to 4 months. And as also in pseudophakic, it can be used as first therapy. Radial optic neurotomy has already been covered by Dr. Preetham. So I'll be showing some case studies. This was our case of 62-year female with hypertension, had right eye CRVO with CME, and had vision of only finger counting 2 meter. And you can see on OCT, a large amount of neurosensory detachment with macular edema was there. Patient received injection in the next 2 months, and you can see the edema started decreasing in the after first injection itself. And this normal foveal contour was maintained even after 2 injections also. As we said, we give it loading dose, and then depending on whether the patient is willing for PRN or treat and extend dose. Other patient had 59-year female, not a known diabetic hypertensive, and she presented with this acute loss of vision, and she had CRVO with CME and vision of only finger counting 3 meter, OCT showing large macular edema with neurosensory detachment. Patient received 3 injections. The macular edema started resolving with the first injection, and you can see after second injection more resolution, and you can see over a period of time the foveal contour almost came back to the normal, and there was almost 500 micron reduction of edema. Another patient, 53-year-old female with hypertension, came with non-ischemic CRVO with CME. Vision was 6/36. We gave injection, and you can see with progressive injection the macular edema reduced, and the patient vision was stable. But when the patient treatment was stopped, after 2 months, again, she developed loss of vision, and the macular thickness of 660 micron, vision was 636, and we did angiography, saw capillary non-perfusion, and this was the macular edema. This time we gave injection Eylea, and after injection Eylea, the patient vision was good, and she got the vision of 6/9 part. And you can see here the OCT is a wonderful tool in prognosticating. You can see the macular ischemia here, but still some of the capillary perfusion is there, and patient was maintaining 6/9 vision. But the patient has been explained that vision may go down in case the disease progresses again and again. Another case, 20-year male. So this was a CRVO of the young patient. Patient received oral steroid and tapering doses. But vision, as a dose steroid was stopped, the patient developed edema again, and the patient this time received intravitreal injection, Accentrix. Another patient, 63-year-old male, having edema. Patient received 2 injections of bevacizumab, but the edema was not going. So this was the time, as I said, we should shift to another therapy in form of steroid. You can see after intravitreal Ozurdex, patient responded dramatically, and vision improved to 6/18. And but the macular edema again recurred after 4 months. Then the patient had macular edema, and patient again received second Ozurdex implant, and the vision improved again. So the take-home message is we should give prompt intravitreal treatment in form of anti-VEGF drug or steroids, and subsequent monthly injection, at least 3 injections. If the vision has stabilized, macular edema has come down, we can choose a PRN regime or treat and extend regime. And steroid may be considered as a first-line therapy with the patient of major cardiovascular event or who is unwilling to come for monthly injection and or pseudophakic patients. Thank you very much.
Thank you, sir, for the great talk. Can we have quick comments from the panelists and the chairpersons?
Okay, I think nobody is responding.
Hello, sir. Can I ask one question? Hello, Dr. Neeraj.
Oh, yeah.
Can we expect to have some kind of a topical or a anti-VEGF in future?
So, research is going on. We are likely to have something like that. But we have seen, we do give Nevanec eye drops in as an adjunct to anti-VEGF therapy because it has been shown giving Nepaflam reduces the chances of macular edema recurrence. So, but topical anti-VEGF drug is on the way. What do you say, Preetam?
Yeah. So yeah, there are some research going on some nano drops and nanotechnology and stuff like that. But what we have to understand is the dynamics of intravitreal pharmacotherapy depends entirely on the vitreous. The presence of vitreous in the cavity of the eye allows the drug to stay there as a depot. Because of the vitreous that the drug stays there, and slowly it acts over the 4 weeks in cases of anti-VEGF and over 3 months in cases of intravitreal steroid. So to come up with a topical agent, and, because the tears, the tears are not like that, right? The tears keep on continuously turning over. There's a turnover of tears. So it is a challenge to develop a topical anti-VEGF which will penetrate effectively and work like an intravitreal agent. Yeah.
It is like any other drug. We are not able to reach up to the retina on the topical drug. So even the concentration, whatever will reach over there, will be too less to be effective.
One question I would like to ask Neeraj, what is your criteria for starting PRP? Let's say in a CRVO case where you started with injections, then when do you look for putting in some laser?
Actually, Preetam, what I've seen with this advent of anti-VEGF drug, when the patient is coming regularly to you with CRVO and macular edema, till the time we are giving anti-VEGF drug, they don't develop any because anti-VEGF is suppressing. And before this advent of anti-VEGF, I was seeing more and more patients who are developing neovascular glaucoma or rubeosis iris. And I do see patients of rubeosis who are lost to follow-up after drugs. After 6 months or 4 months, they come later and they develop rubeosis iris. So now I make it a point, like when the patient after 4 months, I tend to do an angiography when most of the retinal hemorrhages have resolved. If I do significant amount of capillary nerve perfusion at the, I rather do peripheral ablation so that the chances of neovascularization will be reduced.
Right.
Thanks, sir.
That brings us to the end of the meeting. And sir, can we ask? I request Satyajit sir for a vote of thanks.
Thank you, Dr. Shivani. I'd like to begin by thanking our guest speakers first, Dr. Vivek, Dr. Preetam, and Dr. Neeraj for your time and presentation. We are very, very grateful to you, and very, very grateful indeed for you for having sat through the entire webinar. Very, very grateful to you once again. I would like to begin by thanking Dr. Pranav Ranjan sir, our president, who has always been supportive and encouraging us. I'd like to thank Dr. Vibhuti Prasanna Sinha. I'd like to thank Dr. Nagendra Prasad for giving me this opportunity today to participate in the ARC program. I would like to begin by thanking the chairpersons, Dr. Subhash Prasad sir, Dr. Vishal Kishore, Dr. Deepak Agarwal, Dr. Vivek, and Dr. Abhishek Anand, who were there throughout the presentations with us. I would like to thank the speakers, and especially I would like to encourage and really appreciate Dr. Arvind Kumar, Dr. Shivali, and Dr. Gautam for the amazing presentations that they made. I'd like to thank Dr. Asif and Dr. Shivani Sinha for the moderation, amazing moderation that they did. I'd like to thank Dr. Sudhir Kumar sir, Dr. Shalabh Sinha, Dr. Satyaprakash Tiwari, who were with us as chairperson for the second session. I'd like to thank Dr. Pooja Sinha, Dr. Abhishek Kedia, Dr. Siddharth, and Dr. Santosh, who were there with us. Once again, I would like to thank each and all of the participants who were here. And I would like to take 2 minutes to thank Mankind, who sponsored this program. And I'll show you a small video which I want to share with you in support of the great work that Mankind is doing. I'll just take 2 minutes.
Audio is not there.
Thank you so much. I would also like to acknowledge Mankind for the amazing work that they have done by donating money to the families of doctors who have died during COVID. We have known of pharma companies who help doctors who are alive, but helping doctors who have died, their family, and supporting their children and wife, and supporting the spouse is something very amazing that the Mankind has been doing, and we are very, very appreciative of Mankind for that. So we would like to thank Mankind, and I would like to thank Sunil ji for organizing this whole Zoom meeting, who has been in the background organizing all the things. Once again, thank you very much, and I would like to hand over to Dr. Nagendra Prasad for the further proceedings.
Thanks, Dr. Sajit. Again, I'd like to thank all the speakers who have shown beautiful videos, and they have presented very well. All the speakers, those who are presented today, is the quality of the video is very presentation is very high. So at last, I thank our guest speakers, Pritam, Dr. Neeraj, and Dr. Vivek for coming and giving time for and staying till night till now at so late in the night evening. I thank Dr. Pranav Ranjan sir and all the boss officers. Now we take leave, and thanks all from the bottom of my hand.
Yeah,
of my heart.
and looking
Thanks.
forward to another program next month.
Yeah, next month. Yes,
And the best part of the webinar was that we are going to give opportunity to all the young people, the postgraduates, so that they take up the podium, gain confidence, and because they are the future ophthalmologists of the country.
Yeah.
So we have to promote.
And my special thanks to Dr. Sajid, who brought very good program, and he made very effort to bringing out this program to this Sajid. डॉक्टर संजीत को बहुत बहुत धन्यवाद भाई, मैं अपने तरफ से बोलूंगा, मैं इनका और भी लेता रहूंगा। इनका हेल्प मतलब लगता है no webinar or no scientific program is complete without Sajid, so of course he is
he's a star organizer for the country.
Thank you, sir. Now we should leave by now.
Thank you so much, Neeraj. Thank you so much.
Thank you very much.
Bye.